Okay. Yes, madam. Okay. I welcome all of you to this 20th edition of the Clinical Neurology Forum, which we have been conducting every month to bring in case discussions, to encourage our postgraduates, registrars in neurology, and also case discussion to be moderated by professors and assistant professors. And we have a chairperson every month for each of these forums. And today we have Professor Tamil Pavai, Professor of Neurology at the Institute of Neurology, Madras Medical College and Government General Hospital. And she has been with us for, I think, more than 14 years now. And she will be conducting the proceedings. I request Professor Tamil Pavai to take over and conduct the proceedings from now onwards till the finish. You can call the first presenter and the moderator will be there to guide the presenters. Over to Professor Tamil Pavai, please.
At the first instance, I thank our former director of neurology, Professor V.N. sir. Thank you, sir, for giving this opportunity to me.
My pleasure,
and I
madam.
also thank the moderators, Professor Manivannan sir and Dr. Subramanian is a student of MIN. And now I invite the first postgraduate, Harshavardhan, to present this case. Dr. Harshavardhan.
Yes. Good morning, madam. Today I am presenting a CNS case. So,
yeah.
Good morning, madam. A 58-year male patient, right-handed individual, studied up to 8th standard, working as a watchman, hail from the Dindigal, informant by himself, and it is reliable. Coming with chief complaints of
Harshvardhan, can you come closer to the mic, please? So that you will be more audible.
Yes, sir.
Yeah.
Yes, sir.
That's better.
Yes, sir. Hello.
The support tech team, please mute all the others except the speaker, please.
Sir.
Ashwadhan, you can continue, please. அப்பா ஹர்ஷ்வர்தனையும் மியூட் பண்ணிட்டீங்களாப்பா? அவரை அன்மியூட் பண்ணி விடுங்கப்பா.
Sir, patient presented with tightness of lower back muscles and bilateral lower limbs since 3 years, and history of episodic painful spasms in both lower limbs and back muscles since 3 years, and history of difficulty in using both upper limb and lower limb since 1 year. And history of presenting illness. Patient was apparently normal until 3 years. Initially, while doing duty as a watchman at night, he noticed discomfort and tightness of lower back and bilateral lower limbs associated with severe muscle spasms, which is lasted for 6 to 8 hours. So he went to room to take rest, but he is unable to lie down straightly, like by touching legs and feet onto the bed. So he lie down for hyperextended posture, and he is having difficulty in getting up from lying down position and difficulty in turning side to side in bed because of severe tightness and spasms, and it is relieved after some time without any medication. And later he experienced similar episodes 5 to 6 times over a period of 6 months while he attending for a prayer in masjid on every Friday after hearing loud voice of the people or during namaz. So he used to take rest at masjid, and with help of friends he will go to his home, and this episodes will relieved after some time, but in between the episodes he is able to do routine activities without any difficulty. but never he noticed tightness and spasms of upper limb, neck, upper back muscles are not associated with any weakness of upper and lower limbs, or neck pain, or radiating pain, or reduce or loss of sensations. So for these complaints, he consulted a local doctor, diagnosed as a lumbar disc disease. So he started on analgesics, injection vitamin B12, and advised physiotherapy. But patients experience like these episodes multiple times, but symptoms are not subsiding with above treatment. So in between over 3 years, he used to go to work by bus. While traveling in bus, he's experienced similar episode like 2 times. While after hearing sudden horn sound of the bus or vehicles in the road, so with help of co-passengers, he used to guard down from the bus, and he used to call his relatives to take him to home because of severe tightness, unable to walk or unable to get up from the position. So he used to call his relatives to take him to home. Recently, again, one day before Deepavali, last month, he noticed discomfort and tightness of lower limbs. That time he was in Dindigal. So that time he only felt the discomfort in the back. Next day he came to daughter's house in Madurai. By evening, he noticed severe tightness and lower back muscles and both lower limbs with severe painful spasms. So, and he's not able to lie down slightly, and unable to get up or turning side to side. So with the relatives took him to hospital, Rajaji hospital. While shifting him, they noticed his limbs are so tight, like stone or wood. They are unable to move his limbs. By mistake, if they are moving his limbs by touching or flexing a limbs, he used to get severe spasms. After that, he's in meanwhile within 1 year period, he noticed difficulty in gripping the chappals and slippage of chappals with awareness, and he is having difficulty in getting up from squatting position while using Indian toilets and climbing upstairs and downstairs since 1 year. 3 months later, that is 9 months, since 9 months, he had noticed difficulty in buttoning and unbuttoning, opening keys of bike, and he's have difficulty in water bottle opening of water bottle caps, but no difficulty in lifting a hand above shoulder or taking objects from above. He's able to turn side to side in bed in between episodes, but and lift the neck from the pillow. No issue of thinning or wasting of or twitching of muscles. No diurnal variation or fatigue weakness or muscle pain. Sensory history is able to feel the sensation of over the body. Patient able to feel hot and cold water while taking bath. No of numbness or pins or needle sensation. Able to appreciate firmness of the floor while walking. No cotton wool sensation while walking. No worsening of instability in the dark or while washing face. No band-like sensation. No electrical shock-like sensation. Cranial history, able to perceive the coffee of smell, able to differentiate, able to see near and distant object, able to differentiate colors, no issue of drooping of eyelids, no double vision, no issue of difficulty in chewing food or impairment of sensation over face, able to feel hot and cold sensation over face, and no difficulty in closing eyes, and no deviation of angle of mouth, no drooling of saliva from mouth, able to appreciate taste sensation over the tongue. No odd of hearing, no ringing sensation of ears, no issue of nasal regurgitation, or no issue of difficulty in swallowing for solids or liquids, able to articulate the speech normally, no harshness of voice, no difficulty in turning head side to side, no difficulty in lifting the shoulders, able to move the tongue freely inside the mouth, and able to clear the food from the vestibule and able to push the food backwards. And no issue of unsteadiness while sitting or standing, able to speak fluently, no swaying to one side while walking, or both sides. Autonomic nervous system, he is able to feel the bladder fullness, able to hold the urine, initiate micturition and completely void the bladder, no urinary incontinence, no bowel incontinence, no issue of abnormal setting, and no postural giddiness or erectile dysfunction. And his no issue of lapse of memory, no issue of euphoria or anger outbursts, converse well with the parents and family, no hallucinations or delusions, and no issue of involuntary movements of limbs or slowness of daily activities, or except during stiffness, otherwise is no history of recurrent falls. And history of hypopigmental lesions around the mouth, over fingers, over bilateral knees and ankles since 8 years. Lesions are not associated with reduced sensations or itching or redness. No issue of weight loss or loss of appetite, no joint pains or rashes, arthritis or dry or dry mouth, no antipsychotic intake or drug overdose. Past history is not a known diabetic or hypertensive or coronary disease or thyroid disease or HIV, malignancy or seizure disorder. No history of exposure to toxins, no history of high risk behavior. Patient taking oral medication for current problems since 2 years. No history of any surgeries done in the past. Personal history married, is taking mixed diet, normal appetite with normal sleep pattern, no history of any substance abuse. Family history is born out of non-consanguineous marriage, no history of similar illness in the family. Wife died at the age of 40 years with high sugars and respiratory tract infection. Caused, don't know. Having 3 children, 2 daughters and son. Elder daughter is married, having 2 children, and but second daughter having vitiligo and type 1 diabetes and hypothyroid, and she is not married. Son is having vitiligo and type 1 diabetes on insulin, and he is also not married. And summarizing the history, 58-year-old male without any comorbidities or not a smoker or alcoholic with history of hypopigmented patches over the body, and he had family history of vitiligo and type 1 diabetes in son and daughter, presented with multiple episodic type of neurological illness characterized by tightness in lower back and both lower limbs associated with painful spasms, precipitated with tactile stimulation and unexpected noise, without involvement of neck, upper limb, chest or upper back muscles, and is not relieved with medication sincerely, improving after admission with medication, and not precede. These episodes are not preceded by fever, excessive sweating or drug intake or drug overdose, and no and history of weakness of lower limb followed by upper limb, distal more than proximal since 1 year, without any and not associated with any neck pain or root pain or gutty like sensation or reduced or loss of sensation or thinning or twitching of muscles, and no history suggestive of higher mental function, cranial nerve, cerebellar, autonomic or extrapyramidal symptoms. After my summary, I want to localize structures involved are: number 1 is bilateral corticospinal tracts at the level of above
Sir, my
C7,
webinar la sir.
above C7 and below medulla, as evidenced by spastic all 4 limbs. That is
இல்ல நான் காமன் போர்ட்டல்ல எங்களுக்கு எல்லாம் லிங்க்
proximal
ஒர்க் பண்ணுது, நான் உங்களுக்கு அனுப்பி விடுறேன். Thank you.
Proximal distal muscles and distal muscles of upper limb, and spinal cord interneurons, because loss of inhibition at thoracolumbar or sacral is as evidenced by where antagonist agonist muscles are stiff and rigid, painful spasms. So I want to localize because of loss of inhibition at spinal cord interneurons. So with these structures, with the differential diagnosis, first is central demyelination. One is because MS and NMO spectrum, because in this patient favoring points are patient has painful tonic spasm and with occasional rigidity, but unfavor are age of onset and duration, and no other myelopathy feature except corticospinal tract involvement, no optic nerve involvement or diencephalic or area proxima or brainstem involvement symptoms. So it can be possible because patient has paroxysmal episodic painful spasm. So first, to rule central demyelinating disorder. Second is non-compressive myelopathy. Points favor in this are patient has symmetrical motor involvement, where partial corticospinal involvement is favor in this patient, but unfavor are most likely patient has onset of and progression and episodic in nature without any other myelopathic features are absent, and worsening with the loud sound and tactile stimulations are very unlikely in non-compressive myelopathy. In non-compressive myelopathy, it can be differential. We have to rule out is autoimmune, that is secondary vascular, secondary connective disorder like SLE, Sjogren's or sarcoidosis and Becher's disease, or infectious causes can be TB, arachnitis can present like this, and toxin involvement also can like cassava or letharism because patient has severe tightness and rigidity. These 3 can be non-compressive myelopathic causes. My other difference is primary lateral sclerosis because patient has pure motor involvement, or PLS is a human variant of motor neuron disease. In this patient, the favorable history is patient has pure motor spastic weakness and duration. unfavor are patient having symmetry started with symmetry and painful spasms with worsening with loud or tactile stimulation, loud noise or tactile stimulation, but no history other features like thinning or twitching of muscles. And next, my differential diagnosis tetanus. Why tetanus favoring is only because a patient has rigidity and painful spasm, but unfavor in this case because one is duration, that is patient having incubation period of 4 to 6.
Video on the
Hello. Tetanus is my another differential diagnosis where patient has a favor of rigidity and painful spasms, and not favor in this case. One is incubation period of tetanus is 4 to 6 weeks duration, and in here it is episodic and which is not preceded by any trauma, surgery, or any fever or sore throat. And in this tetanus also patient will have trismus or rhizus sardonicus with the descending weakness, descending paralysis. So it is also only the favoring is rigidity and painful spasm. Next is stiff person syndrome. According to Dallac's criteria, patient having feature of rigidity, painful spasms involving the lower back muscle, that is axial muscles, bilateral lower limbs, which is worsening with the tactile stimulation or loud noise. And so strong possibility in this case is stiff person syndrome. But unlike but patient has having of corticospinal tract, that is one confusing other than this symptomatology, only patient having corticospinal involvement. Next closest differential is neuromyotonia or Isaac syndrome. It is a peripheral nerve hyperexcitability disorder as manifested with painful spasms and rigidity as like is there in my patient, but patient has episodic involvement and worsening with tactile stimulation and sound. It will not be there in neuromyotonia, and patient will have any autonomic symptoms and encephalopathy features will be there in neuromyotonia. So it can be differential after my examination. Second is next is hereditary spastic paraplegia. Why? Because favorable points in this patient is patient has pure motor involvement in the form of severe rigidity and spasms, but in HSP variants they can present with spasms also, but unlike in these patients are worsening with loud noise and tactile stimulation. Next, my differential is focal limb dystonia because patient has severe rigidity and with sustained posture of limb, but again it is episodic in nature and worsening with tactile or loud noise. Next is akinetic rigid syndrome. It is more unlikely. Patient didn't have any extrapyramidal features or hyperkinetic features not there. So except the patient has akinesia and rigidity. It can be one of differential diagnosis. Next is NMS, neuroleptic malignant syndrome or serotonin syndrome, where antipsychotic drugs intake or overdose, where they can present with severe spasms with rigidity, and but here duration one is unlikely, and the patient didn't have any autonomic disturbance like excessive salivation or temperature, hyperpyrexia, or any other worsening of symptoms. Autonomic symptoms are not there, so can be differential. And history of drug intake is not there, so it is unlikely. Next to my differential is ankylosing spondylitis, where in this patient favorable points are patient having axial rigidity and lower axial rigidity and lower back muscle pain and spasms, but one is duration and patient didn't have any other, and worsening with tactile and loud noise without any features of uveitis and sacroiliitis, so it is also unlikely. So we have this 11 differential diagnosis to work up my case. So next, on general examination, can I continue?
Ashwardhan, please wait a minute.
Sir, okay.
Madam, comments from the audience or comments from you or anybody?
You told, Dr. Harshvardhan, you told it is a central demyelination MS bar NMO spectrum disorder. Do you get
No, yes,
tonic
madam.
spasms as an initial presentation of all these?
Yes,
And it is
madam, they can present they can present with the paroxysmal tonic spasms, in a different NMO spectrum disorder where central myelin demyelination is there. They can present with paroxysmal painful tonic spasms.
That is there, but you get as the initial manifestation, the patient presented only with episodic spasms and stiffness. But that
Stiffness,
is not
yes,
the initial presentation of an NMOSD or a multiple sclerosis. You can have, but how common is it? How common is
Very
it?
rare. It is
Ah.
rare presentation. Actually, it is rare presentation. But the patient having painful tonic spasms. So I want.
No, you're right only,
keep
but
it as
that
a-
should not be put on the top of the differential diagnosis in the list. Okay.
Okay.
And what is
Okay.
a non-compressive myelopathy you told? It was very non-specific, like non-compressive myelopathy presenting with tonic spasm. What is it you want to think about?
In this patient, I want to why keeping the non-compressible patient can second autoimmune like SLE, Sjogren's or sarcoidosis. They also can present with demyelinating with having painful tonic spasms. And second is infectious, post-infectious like TB arachnoiditis can present also with tonic spasms, painful tonic spasms with spasticity. So I want, because of that, I keep as a non-compressive myelopathy.
So
And,
you have listed the host of differential diagnosis. You feel which you want to keep first on the top of it. First, you should have an anatomical localization.
First.
The structures involved. You told both upper limbs are normal, if I remember. And
Distal
you told
only.
the upper limbs
Distal
are
upper
normal.
limb is.
Huh?
Distal muscles of upper limb is weakness is there. Distal muscles of upper limb also
Upper limb are
weakness is
weak.
there. Yes,
But the
ma'am. Yes,
patient,
ma'am.
that he told in the history, or you asked? Patient
No,
told
madam.
that.
Because he noticed this is since 1 year, madam. That is since 3 months only. Last 3 months later, means he is since 9 months he has distal weakness, madam. Because he told clearly he is having difficulty in opening keys of bike and is unable to buttoning and unbuttoning compared to before, madam. That history is there.
Okay.
Distal
And,
proximally is telling completely normal, madam.
Then among all the differential diagnoses enumerated, you want to put
Yes,
which at the top of the list?
First my is Chief-Person syndrome, madam. Second is neuromyotonia or Isaac syndrome. And this two is my top of the list, madam.
You want to, is the criteria fitting into NMO,
Yes,
that
madam.
is neuromuscular syndrome, that is
No,
NMO,
madam. No,
serotonin
madam.
syndrome?
That's why no, madam. Patient didn't take any antipsychotic medicines, madam, except rigidity and painful spasm. He didn't take any antipsychotic or no autonomic disturbances is not there, madam. That is also.
Okay.
Yes, madam.
Any of
My
the
top of the list is this.
Any of the participants from MMC, can you discuss this case? Your anatomic localization, any of the participants from MMC want to opt for it? Any of the participants?
Madam, I would
come?
just like to make a comment, madam.
Yes,
Harshvardhan,
Madam, can I come?
Sir.
Vijayan, okay, you go Vijayan, then I'll come.
Because MMC சொன்னதுனால நான் Madurai Medical College.
Anybody is welcome, sir. Sir, anybody is welcome.
sir.
Go ahead.
Madam, I first want to congratulate the presenter. Excellent clinical discussion of the case,
Yeah,
madam. It was
definitely.
as if like going through the New England Journal of Medicine. Excellent. The way he put out the differential diagnosis, way he explained, it was excellent teaching points which he made. I must congratulate the presenter for this, madam. Then no other comments. Thank you.
Okay.
From
Madam,
Madras Medical College.
Madam, with your permission, I would like to make a comment. I would like to ask a question of hers. Harshvardhan, you have presented only the history. We have not gone into the clinical findings. Correct?
Yes, sir.
Yeah.
Yes, sir.
Now, what makes you say from your presentation of the history, what makes you think that the corticospinal tracts are involved? Because your discussion seems to revolve around corticospinal tract involvement. What is there in this
Yes, sir,
history? Go ahead.
Sir, patient has patient has weakness of distal muscles, sir, followed by proximal muscles, and he is having distal weakness is more than the proximal weakness. And because of this, and the patient is like sequentially one, sir. He has involvement of lower limb followed by upper limb, and is more of distal, sir. So because of this, I want to locate it as a corticospinal tract, sir.
Okay, can I discuss that point?
Yes,
See,
Yes, sir, yes.
As I said, we are in the history. We have not examined the patient. We do not
Yes,
know
sir.
which is more, which is less. All those we do not know at present. The distal involvement came subsequently. The primary involvement was painful involvement of the muscles and of movement and stiffness. These were the predominant complaints. He was finding it difficulty to move, get into a bus, travel, and any noise or sound or any touch, any stimuli for that matter, made him
Yes, sir.
worse.
Yes, sir. Yes, sir.
Okay, okay.
Yes, sir.
Now, let me first ask you, with
Sir.
these symptoms, we are only discussing symptoms, which you have mentioned.
Yes, sir.
What anatomical site would you think the lesion can be? Just tell me the anatomical site where the lesion can be.
Sir, we thought of initially muscle involvement, sir.
No. Sorry. Hush. 1 minute.
Sir, sir.
You are an exam going postgraduate. There is no
Sir.
question of we. It is you.
Sir.
You
Yes,
have
sir.
to say what you thought. See,
Sir, I thought
this
of
is a preparation for your exam.
Yes, sir.
So you should tell me the anatomical substrate. See, you listed 11 differential diagnoses.
Yes, sir.
And that, unless you have an anatomical substrate, how can you narrow down the differential diagnosis? Several of these differential diagnosis, will not stand scrutiny if you localize to an anatomical substrate. First, tell me what, in your opinion, is where the likely pathology is, in which anatomical substrate?
My anatomical subject is mainly in spinal cord interneurons, loss of inhibition, sir. Because the
Okay.
patient.
See, that is again a technical, what should I say, a literature review based on which you are saying, depending on what condition you are talking about. You cannot diagnose an interneuron involvement with the symptoms. Have you ever diagnosed, based on the symptoms, an interneuron involvement of the spinal cord? What is there for, let me ask you a straight question. Pardon me for asking that, but I think it is one of the reasons for these forums. What is there
Yes,
to make you suspect the spinal cord? Because you started off, as Tamil Pave Madam asked, you started off as central demyelination, you started saying MS, NMO spectrum. Where do you get all this? Where are those symptoms for those? What is the core symptom? Are the core symptoms which you mentioned, are they a feature of central demyelination or MS or NMO? That is why I'm asking you.
No, sir. No, sir.
No, that is why I'm asking you, based on the symptoms, where do you think the likely pathology is likely to be? See, what
Cortical spinal tract, sir.
no, okay. You still say cortical spinal tract. Okay, I come back to that.
Yes,
What did you say was your first, when Tamil Pave Madam asked you, you said your first diagnosis. What were your first diagnosis? First two diagnoses?
My stiff person syndrome, sir. First, stiff person syndrome. Next is neuromyotonia, sir.
These were the two syndromes. Wait a minute. These were the two diagnoses you offered. Am I right?
Yes, sir. Yes, sir. Yes, sir. Yes, sir.
Those were the first diagnoses which you offered.
Yes, sir.
Right.
Yes,
now
sir.
Tell me, in which of the two which you mentioned, in which of the two do you get cortical spinal tract involvement?
No, sir. That's why, sir. In this patient has cortical spinal tract involvement. So because of that, we got confused.
Just a minute. Sir. We have not examined the patient. We are only discussing based on the history. Tell me the historical point on which you say the cortical spinal tracts are involved. And yet, having said that, your first two diagnoses are stiff person syndrome and neuromyotonia. How can you explain that? Tell me. See, you will have to be definite. It's one thing to list a lot of differential diagnoses, but you have to be clear where is the likely pathology. And the likely pathology ki neenga 10, 20 differential diagnosis kudukkalam. If you say it's a cortical spinal tract involvement, you can give 20 differential diagnoses for cortical spinal tract involvement, provided there is evidence in the history of cortical spinal tract involvement. Now, okay, we'll come this way. Vijay, yes, Vijayan, you go ahead.
Illa sir, I just want it was an extensive based only on history, illa sir. So I think at this
Correct.
stage we need not go too much into
This
the
is
details.
only a questioning on the history, Vijayan. This is only a
At this
questioning.
history stage, I think we need not go too much into the details, illa sir.
Illapa, our exam for our pa. No. I won't take that answer. He is an exam going postgraduate, so he should know how to go about it in an exam. I'll come the other way around.
Yes, sir.
If you don't
Also,
mind, Vijayan, if you
yes,
don't
sir.
mind.
Sir,
Madam?
Dr. Ramla, as VN sir told, he's an exam going postgraduate. I think we leave to VN sir's discussion. I think he's doing it in the right track, sir. We have to look more into the history as VN sir is doing the correct way around, I feel, sir. Vijayan sir.
Vijayan,
No,
pardon me, Vijayan.
Illa sir. I'm not. I'm just telling that he is given a wide diagnosis.
நீங்க சொல்றது correct. If it was somebody else who was discussing the case, I would not have interfered at all. But since he is a postgraduate who is exam going postgraduate, I feel it is my duty to tell him what he should look for. I'll come back to Harshvardhan. I'll come back to you. Ipo neenga solunga. What is the anatomical substrate in a person with a stiff person syndrome or neuromyotonia? What is the anatomical substrate in them? So that's our first diagnosis. நீங்க extensive discuss பண்ணீங்க, நான் அது மறுக்கல. Very good. But what is your first diagnosis? You said stiff person syndrome and neuromyotonia. Appo on the conditions la, which is the anatomical substrate which could be involved? Adu solunga enakku.
One stiff person syndrome mainly because of loss of inhibition in spinal interneuron. That is only the anatomical substance.
Appa nee again literature review ku pora, nee straight stiff person syndrome poi interneuron involvement ke solra, right? Adu utru. In the symptom, where will you think that which anatomical substrate is disordered? Let me say that. Where is the disorder? No, clear. Okay, let me ask you again. Neurology discuss. You said stiff person syndrome or neuromyotonia. Is it a low motor neuron involvement or an upper motor neuron involvement? History only தான் பேசுறேன்.
Lower motor, sir.
Lower motor neuron. Solitaire lower motor neuron solitaire. Sir, very good. Lower motor neuron la muscle இருக்கு, neuromuscular membrane இருக்கு, peripheral nerve இருக்கு, root இருக்கு, anterior horn cell இருக்கு. இதுல எது involved ன்னு நினைக்கிறீங்க?
Sir, stiff person sir, muscle involvement sir.
அப்பா நீ stiff person விட்டுடு. நீ symptom diagnosis base பண்ணி டிஸ்கஸ் பண்ற பாரு. நீ first symptom base பண்ணி டிஸ்கஸ் பண்ணணும். நீ diagnose பண்ணேன்னா you already fixed yourself. That will always land you in problems. That is one of the things which we have to be very clear when we are discussing a history. We should not formulate a diagnosis and push in the history to fit in with the diagnosis. I agree with you that your primary diagnosis based on the presentation was stiff person neuromyotonia, right?
Yes, sir.
But இப்போ நான் கேட்டல low motor neuron சொல்லிட்டீங்க. நான் அதுக்கு திருப்பி வருவேன். Once you said it is a low motor neuron involvement, which anatomical substrate சொல்ற? எந்த ஸ்ட்ரக்சர்னு சொல்லுவ?
Muscle, sir.
Excellent. So muscle localize பண்ணிட்டீங்கல்ல?
sir.
கரெக்ட்டா? Right. So இப்போ நீ muscle-னு நீங்க localize பண்ணிட்டீங்கன்னா, இப்போ நீங்க differential diagnosis சொல்றது வந்து will revolve around conditions which involve the muscles which can give rise to these symptoms. அப்படி பார்த்தீங்கன்னா என்ன, நான் இதான் விஜயன்ட்டு சொல்றேன். See, இப்போ என்ன ஆகுதுன்னா உங்க சென்ட்ரல் டீமைலினேஷனோ நான் கம்ப்ரெசிவ் மைலோபதியோ பிரைமரி லேட்டரல் ஸ்க்லரோசிஸோ ஹை அப் இந்த லிஸ்ட் வராது. யூ ஆர் புட்டிங் தோஸ் ஹை அப் இந்த லிஸ்ட். அதெல்லாம் டிஃபரன்ஷியல் டயக்னோசிஸ் எக்ஸ்க்ளூஷன்ல வேணா வரலாம் when you are not able to fit in something definite. அதெல்லாம் முதல்ல போட்டீங்கன்னா நீங்க எங்க கொண்டு போறீங்க? பிரின்சிபலி இன்வால்விங் த ஸ்பைனல் கார்ட். நீங்க சொன்ன மாதிரி பிரமிடல் ட்ராக்ட்ன்றீங்க. பட் ஆனா நீங்க லோக்கலைஸ் பண்றது எங்க? லோவர் மோட்டார் நியூரான் மசில்ல லோக்கலைஸ் பண்றீங்க. See, இப்போ என்ன ஆகுது பாத்தீங்களா? Your localization is somewhere and the conditions which you list is somewhere else. This is what you need to, please pardon me, please forgive me if I'm, it is not a criticism at all. This is a class which I am taking, that's all. I'm just guiding you how to go about in your thinking.
I'm totally agreeing with you, sir. I'm totally agreeing with you. This is how it should go about, sir.
அதனால நீங்க differential diagnosis, confine yourself differential diagnosis to muscle involvement. You said your first diagnosis is stiff person neuromyotonia. Absolutely fine. அதே மாதிரி அந்த மசில் இன்வால்மெண்ட்டுக்கு நீங்க டிடி சொல்லுங்க. நீங்க சென்ட்ரல் டீமைலினேஷன், நான் கம்ப்ரசிவ், பிஎல்எஸ், ஹெரிடிரி ஸ்பாஸ்டிக் paraplegia, இதெல்லாம் கண்டிஷன்ஸ் wherein primarily the core symptomatology should involve the spinal cord or the pyramidal tracts. அதனால அதை விட்டுட்டு மசில் இன்வால்மெண்ட்டோ இல்ல மசில் தான் இருக்கணும்னு அவசியம் இல்லை. இப்போ நீங்க நியூரோமயோட்டோனியா சொன்னீங்க, நியூரோமயோட்டோனியால எது இன்வால்வ் ஆகுது? Exactly. So as you said it's an element disorder. Element disorder, it can be a muscle, it can be a muscle membrane, it can be myotonia, which is muscle membrane can cause myotonic problems also, or peripheral nerves. So your differential diagnosis should be confined to those. Okay, that doesn't matter. I just wanted to, it's only a teaching session. You rest also pardon me, Vijayan also pardon me, Harsh also pardon me, Subramaniam pardon me. But I think I'll have to do this. Okay, now you go, madam, if you want, you can go ahead with the examination as event.
Sir, one small.
Yes, sir. Yes, sir. Yes, sir. Please,
Sir, I am also from MMC, sir, Madurai Medical College.
Sir, தெரியும் sir. ஈஸ்வர் தாஸ் போலுங்க sir. நீங்க விஜயன் எல்லாம் மதுரை மெடிக்கல் காலேஜ் தெரியும் sir. சொல்லுங்க sir.
இல்ல sir, as a general practitioner in neurology, what I think, sir, in history, you ask the opening of the mouth, the problem because of the rigidity with the episodic spasm of the muscles precipitated by the movements or noise, and another close differentiated tetanus, only differentiating feature. Here it's a trismus, because even though stiff person syndrome, very rarely they can have a trismus, but tetanus predominantly the trismus are so I think the history we can think of this possibility also. Tetanus.
Tetanus mention பண்ணாரு.
ஆமா எழுதிருக்காரு சார். So short
mention பண்ணாரு, டிஸ்கஸும் பண்ணாரு. அஸ்வதன், tetanusக்கு என்ன சொல்றீங்க நீங்க? சார் tetanus சொல்றதுக்கு?
Sir, because incubation period for tetanus 4 to 6 weeks, sir, and patient will have facial trismus and riser sardonicus will be there, and
correct pa, அது இருந்தா இல்லையா?
இல்ல சார், எதுமே இல்ல சார்.
அத சொல்லிடுங்க. ஈஸ்வரதாஸ் ட்ரிஸ்மஸ் இருக்குன்னு நினைச்சிட்டு சொல்றாரு, அதனால தான் இல்லன்னு சொல்லிட்டேன்.
இல்ல, நோ சார், நோ ட்ரிஸ்மஸ் சார்.
Okay, madam, it's on to you.
Yeah, like now you proceed further on with the clinical examination, neurological examination.
So, on general examination, right-handed individual, conscious, oriented, comfortable, and cooperative. Height is 158 centimeters, weight is 57, BMF 22.4. No pallor, icterus or cyanosis, clubbing, lymphadenopathy, or pedal edema. No neurocutaneous markers are noted. Hypopigmented patches present over the body, such as vitiligo. No features of vasculitis or connective disorder. So, like this one, rashes and rashes, or dry eyes, dry mouth, and patient no peripheral nerve thickening. And vitals are is afebrile, pulses 86 per minute, normal volume and character, and no radial or radiofemoral delay, on peripheral pulses are felt, and no thickening of vessels. BP is 110 by 70 mm Hg, and right upper limb in supine position, and no postural drop. Respiratory rate is 16 per minute, abdominothoracic type, and it is regular. This is the patient pictures showing vitiligo mainly around the mouth and fingers and bilateral knees and links. And higher mental function is conscious, alert, oriented, time, place, person. Memory is immediate, recent, remote is intact. Speech fluency, his comprehension, verbal output, reading, intact, and reading, writing, repetition, and naming is normal. MMSC 29 by 30, except is unable to write. Otherwise, he is 29 by 30. No emotional liability, no hallucinations or delusions. Cranial examination, cranial one. Sense of smell, cough and camphor, both right and left is normal. Visual acuity 6 by 6 bilaterally. Field of vision by confrontation test, normal bilaterally. Color vision by ECRS chart is normal. Fundus is normal. And 346 cranial nerves. Air movements are eye movements are normal bilaterally. Pupil side 2 mm bilaterally. Direct reflex is present bilaterally. Concentric reflex present bilaterally. No ptosis or no squint. No nystagmus. Accommodation reflex is present. Ocane is normal. Fifth nerve, sensation over the face and buccal mucosa is normal. Motor, masseter, temporal pterygitis is normal bilaterally. Reflexes, the corneal conjunctival reflex and jaw reflex is absent. Corneal conjunctival reflex is present bilaterally. And motor, seventh nerve, motor, nasolabial flow normal bilaterally. No hyperacusis. Occipitofrontalis, orbicular artery, orbulus ovaries, and bassinator and plasmide is good. No weakness bilaterally. It is good. Sensory taste of anterior 2/3 of tongue is normal. Sensation over the tragus is normal bilaterally. Reflexes, corneal conjunctival reflexes present bilaterally. Secretomotor, moistness of the eyes, tongue, and buccal mucosa is normal bilaterally. Eighth nerve, Rinne's test is positive bilaterally. Weber test is not lateralized, and head impulse test is negative, and Foucault and star walking is not able to do. Ninth and 10th, ula palatal arches and movements are centrally placed and symmetrical. Gag reflex is present bilaterally. Palatal reflex present bilaterally. 11th, trapezius endochleum is good bilaterally. 12th nerve, tone is normal bilaterally. No wasting, no fibrillation. Tongue protrusion to midline to on either side is normally. Coming to motor system examination, bulk inspection is normal, palpation is normal bilaterally. Measurements, upper limb 10 centimeters above acromion process, 24 centimeters below acromion, 20 centimeters bilaterally. Lower limb 18 centimeters above tibial tubercle, it is 38 centimeters bilaterally. 10 centimeters below tubercle, 29 centimeters. And tone, upper limbs hypertonia in all shoulder, elbow, and wrist region. Hypertonia is there. Lower limbs also, hip, knee, and ankle hypertonia is present, and trunk and axial muscle hypertonia is present. And high power neck muscles is good. Upper limb, shoulder flexion and extension, abduction and adduction is 5/5 bilaterally. Flexion, elbow flexion and extension 4/5, and wrist dorsiflexion, plantar flexion, abduction and adduction 4/5, and hand group is weak. And small muscles of hand is no waist, but no wasting. Lower limb, hip, it is lower limb, it is showing pyramidal pattern of weakness, where hip is extension more weaker than flexion, and abduction more weaker than adduction, and internal extension, rotation, external rotation is 4/5 bilaterally. Knee flexion is 4/5, extension 4-5. Ankle dorsiflexion and plantar flexion 4/5 bilaterally. Toe group is normal bilaterally. So superficial effect, corneal conjunctival, pharyngeal, palatal, abdominal present bilateral. Plantar is bilateral extensor with jaw reflex is absent, and trapezius reflex and pectoralis reflex is present. Biceps, triceps, and supinator is brisk. Finger flexion is present. Knee jerk exaggerated, and ankle jerk is present, and patellar ankle clonus is absent. Primitive reflexor, palmomental, rooting, sucking, snout, and glabellar is absent bilaterally. Coordination, it's tested along with cerebellum. Gait is spastic gait with excessive lumbar lordosis. Sensory system examination, testing of spinothalamic by crude touch, pain, and temperature normal bilaterally. Posterior column, fine touch, vibration, position sense, Rambach 6, position sense is normal, and Rambach sign is negative bilaterally. Cortical sensation, 2-point discrimination is normal. Tactile localization, capacitance, serognosis is normal. Cerebellum examination, no titubation, no truncal stance ataxia, no nystagmus, speech is normal, no pendular knee jerk, no rebound phenomena. Finger nose, finger test is normal, no dystonic opinion, no intestinal tremor. Knee heel test is performed, but with difficulty due to weakness. Is tandem X unable to perform. Next, autonomic nervous system, postural hypotension is absent, nesting tachycardia is absent, no abnormal sweating, and signs of meningeal irritation, no neck stiffness or carrying sign or buoyancy sign. Examination of the spine, no bony deformities and bruit or gibbous or tenderness is absent. Cranium is no bony abnormalities, bruit is absent. No peripheral thickened nerves, no tropic ulcers, no vista or foot drop, carotid pulses and bruit, no carotid pulse is present, no bruit. Examination of other system, cardiovascular, respiratory, abdomen is normal. Clinical diagnosis, 58-year-old male without any comorbidities, presented with episodic, now improving after admission with of tightness of lower back, bilateral lower limb muscles with painful spasms, respirated with loud noise, tactile stimulation, and with spastic weakness upper and lower limb, distal more than proximal. An examination, vitiligo present, hypertonia of all 4 limbs, rigidity of axial muscles, that is board-like or fin-like rigidity, and hyperreflexia, bilateral plantar extensor, and spastic gait with lumbar lordosis. probably with Schiffferson syndrome with CSM cervical spondylotic myelopathy, where patient having cut spinal tract as a clinical diagnosis. Can I go for investigation, madam?
Sir,
Wait. Let us ask for opinion from others.
sir, I want to add a few points, sir. Subramanian, sir. Sir.
Vijayan, go ahead. Yeah, Subramaniam.
Yes, sir.
Yeah, go ahead, please.
Yes, sir.
Madam,
Actually,
yes,
sir. At the time of admission, patient was completely in bedridden state. His lower limbs were very stiff. He couldn't move his both the lower limbs. Both the active and passive movements, knees, hips, everything is severely restricted. So we started to give diazepam. Only after giving diazepam, we could be able to move his lower limbs. It was very painful and it was very hard. This examination, this much was possible only after 3 days of giving diazepam. We gave diazepam initially IV and then oral 10 milligram 6 hourly. Then patient became ambulant within 4 to 5 days of admission. So such a dramatic response to diazepam.
Okay.
One question. Did he have myoclonus?
No, sir. Myoclonus not there, sir.
Okay, but he had a startling response?
Yes, sir.
No, sir.
No startle, sir, but he
No,
has
sir.
loud noise, tactile stimulus is worsening of spasm, sir. While
Yeah,
touching,
okay.
he is having.
Touching as well as noise, both.
Yes, sir.
I'm sorry, abdominal reflexes and cremastic are absent or present or exaggerated.
Sir, abdominal reflex is present, sir.
Yes, sir.
Dr. Harshavardhan, another one question. You told weakness, there is hypotonia. You wanted to tell weakness. What is a pattern of weakness? What is a pattern?
Pyramidal pattern. Lower limb is pyramidal pattern.
So you now tell, I feel you've put all the powers same. Any difference between the lower limbs and upper limbs?
Yes, lower limbs power. See, lower limbs difference is there. Extension more involved than flexor, and abduction are more involved than the adductors, and internal extension equal. Knee also extensions are more involved than the flexors, and ankle and those flex. So it is more of pyramidal pattern of weakness, lower limb.
So what is the pyramidal pattern of weakness in the upper limb?
Upper limb only distal weakness is there, and proximal no weakness. Wrist and elbow is 4/5 bilaterally, and dorsiflexion and plantar flexion 4/5 bilaterally. Hand grip is weak, so he has only distal weakness. Proximal, he didn't have any weakness.
Then the lower limb, I'm not convinced about this pyramidal pattern. What are the group of muscles which are involved in the pyramidal pattern of weakness?
Pyramidal pattern, they'll have
muscles, which movements are more involved?
Upper limb flexor. Upper limb flexors are more in pyramidal pattern. Upper limb flexors, lower limb it will be extensors, and abductors more. Hello.
Tell me.
Can I audible, madam?
Yeah, you're audible.
That's when patient will have upper limb more of extensor involvement. Lower limb flexor involvement will be more of pyramidal pattern. In this patient, flexor is more
flexors. Which flexors are involved? Dorsiflexors of the foot, knee flexors.
Yes, ma'am. Knee flexors, dorsiflexors are weak, and hip flexors. And patient has hip abductors more weaker than the adductors.
Then inverters
so, and but actually in this patient, internal rotation extension equal, in this patient.
Okay. Always when you put the pattern of weakness and you want to come and you should show a pyramidal pattern of weakness. When you tell it is a pyramidal system which is involved.
Yes, pyramidal pattern.
So there's definitely a difference between the flexor and an extensor group. And hypertonia, it is the same
yes,
flexor and extensor. What is the hypertone and the pyramidal tone? No. How is the tone? You put, I think, equal. Go to the tone.
Yes, ma'am. It is.
You put, I think, flexor and extensor. Hypertonia in which group?
Which is both are hypertonic.
Yeah, yes, pa. Hypertonia in the upper limbs, which group is involved, and lower limb, which group is involved?
Upper limb, madam, lower limb, both are involved.
Harshvardhan,
sir.
Hypertonia includes spasticity and rigidity. Now,
yes, sir. In this patient,
spasticity or rigidity that you are talking about?
Sir, actually in this patient, more of rigidity rather than spasticity, sir. Because the patient has one is involvement of both agonist and antagonistic muscles are there.
இல்லப்பா
And
அது
patient
theory
has
வேண்டாம்.
velocity.
No.
Yes,
Theory
sir.
விட்டுடு.
In this
On
patient,
examination,
sir,
did you find that the increased tone was rigidity or spasticity?
rigidity, sir. More of rigidity, sir.
அப்ப அதை
in this
சொல்லணும்ல
patient.
மேடத்துக்கிட்ட.
Yes, sir.
Madam asked for pyramidal involvement pattern of tone involvement.
Sir, actually weakness we can able to localize by pyramidal weakness, sir. But examination tone
Forget
will be
about the
hypertone,
weakness.
sir. More of
Forget about
rigid.
forget about the weakness. Always don't go for the small things. Don't go for the main things, core things. Weakness was by history, he said distal. Okay.
Yes, sir.
How much of a difference
Yes.
is going to be there between proximal and distal, and how much of a distal? See, have you seen patients with Parkinson's disease? Are they comfortable with distal movements, with opening the bottle, so unscrewing the cap and other things? Are they comfortable?
No,
Do they
sir.
have
No, sir.
difficulty or they don't have difficulty?
They'll have side difficulty.
They have difficulty in mixing food. They'll have difficulty in taking the food to the mouth. They'll have difficulty in opening the caps. And is it due to pyramidal
Yes, sir.
involvement or is it due to extra pyramidal involvement? Or whatever it is. I mean,
due to
let's say the rigidity.
Extra pyramidal.
So why do you harp on pyramidal involvement when we are not specific about a particular symptom being due to that? Of course, you found some distal involvement. See, again in
Yes, sir.
distal involvement, this another thing I'll tell you, a clue. Hand grip, particularly hand grip. When you ask the
Yes,
patient
sir.
to grip, you will find it to be weak. But when you
Yes.
ask them to continue to grip, in extrapyramidal involvement, the grip improves as they
Improves.
continue to grip. Initially, the grip
Yes,
will
sir.
appear to be weak. But if you ask them to
Okay,
keep
sir.
on pressing, the grip will improve. And that is not
Yes,
a
sir.
weakness due to a muscle or a pyramidal involvement. That is part of extrapyramidal involvement per se. You give them time and the
Okay.
power will improve. Okay.
Okay, sir.
So, anyway, that's
Okay, sir.
beside the point. That doesn't matter. So it is rigidity, which is what you are saying about, and not necessarily spasticity.
Yes. The more of rigidity, sir.
Okay.
Okay,
Continue.
continue.
Sir, investigation, sir, hemoglobin 13.6.
No,
total
are you
count is
comfortable? Are
7,000.
you comfortable with the diagnosis of stiff person syndrome here? What is atypical
Yes.
about it?
The
And one other
involvement of
thing,
corticospine.
one other thing, did you palpate the back? How was the back?
Yes, sir. That's I mentioned, sir. A patient has severe rigidity of axonal that is board-like and wooden-like, sir. We
On
can able
palpation.
to-
On palpation.
Yes, sir. Palpation.
Yes,
sir.
okay,
Yes,
that
sir,
is
yes, sir.
important. Go ahead. Right,
And
sorry.
abdomen also is very stiff, huh? Harshvardhan, doctor? Abdomen
Yes, sir.
also-
Abdomen also, madam. Very
Okay.
stiff, madam. He's unable to turn. Very stiff.
Okay, proceed.
So investigation wise, hemoglobin 13.6, sir. Total count 7,600. Neutrophils 64%, lymphocytes 32%, monocyte 3, and eosinophils 1%. Platelet count 2.8 lakhs. ESR is 14, and CRP is negative. Peripheral pain, normocytic, normochromic anemia. Viral markers are negative. Serum TSH is 1.54. Anti-TP is 12 international unit per ml. It is normal range. RBS is 124. FBS is 96. PPBS is 128, and HbA1c is 5.8. Serum urea is 28, and creatinine is 1.2, and serum sodium is 130. Potassium is 4.5. All are within normal, and LFT is normal. This is MRI imaging, MRI brain with MRA and MRV. MRA is completely normal. Vertebral artery, both carotid artery and basilar and artery and antecerebral, middle cerebral, everything is normal. Venous system is normal. Sagittal section is all cuts completely normal. MRI brain and normal. This spine, sagittal section showing a T2 weighted sagittal section showing C5, C6 disc protrusion with tical indentation. Otherwise, without any, not much compression, and lumbar level, it has extensive lordosis is there, and having mild compression at the level of L3, L4 with disc protrusion with tical indentation. And the axial imaging is completely normal. CSF analysis we done for to rule out other causes, demyelinating causes or infectious. Cell count is nil, sugar is 34, protein is 24. CT chest and abdomen to rule out other malignancy associated with in this condition. We have to rule out. We did, it is normal. Nerve conduction study for sensor and motor of all four limbs is normal. EMG showing simultaneous and continuous firing of paraspinal muscles and agonistic and antagonist motor units of lower limb muscles. This is the EMG in spontaneous activity. This continuous firing of motor units in spontaneous activity.
Dr. Harshvardhan, what
This
was
is
the
MUP.
insertional activity? You're commenting about the
Madam.
insertional activity or spontaneous activity?
Spontaneous activity, madam.
On contraction.
This is no,
Insertional
madam, not
activity, nothing
contraction. That
was
is nothing as there, madam. Just normal, madam. Is only in spontaneous continuous firing is there, madam. And this is MVPs, madam. Next to one is MVPs where we gave movement, madam. On
that's what I'm
movement,
asking.
patient has.
Ashwardhan, one is at rest, insertion activity, one needle port or activity or the insertion activity.
Yes, second is,
continuous muscle fiber activity at rest, when the muscle is at rest. Yes, minimal voluntary movement, maximal voluntary movement. This is how you need to describe.
Sir, this is first spontaneous activity, sir. First one.
But I think
this is at rest, sir.
I think that is insertion activity you're telling.
This is
huh?
This activity. This is at rest. Next one is at patient having MUP, sir.
Okay. I wanted to ask you one thing. Do you have a video of his walking? Do you have a video of his gait, Harshvardhan?
Sir, is there, sir? Last I am saying, sir.
Okay.
Treatment.
Are they coming here?
This is in interference, man. All showing continuous firing pattern. Next, this is ANA IF is negative. We did for ANA profile. Everything is normal. ANA profile is normal. Next, we went for GAD antibodies. GAD 65 antibodies positive. That is 2246. It is
no,
international
put
per
in the
ml.
slideshow mode. Dr. Harshvardhan put in the slideshow mode.
That's fine. This is a patient having before this ANA profile completely normal, madam. ANA IF and ANA profile is normal, and anti-GAD 65 antibody it is positive. That is the 2246. Reference range is less than 10 international units per ml. So we gave. This is the gait of the patient.
No, you would only 1 minute. Did you do serum or CSF?
We did serum, madam. Serum.
Okay. By criteria, it is okay. This value.
Yes, madam. The patient has the value is okay. The patient has a reference range less than 10 minutes. In this patient, 2026.
What was the assay used?
When?
What was the assay used in finding this antibody?
Don't know.
Okay. You proceed.
This is the gait of the patient after treatment. This is after recently follow 1 week back. He is improved.
Before that, you don't have a video of his earlier walk, huh?
No, sir. Patient has severe rigidity and that spasm, sir. So that time he is we didn't take, sir, actually.
Okay, do you find anything abnormal in that walk? I'm not able to see very well.
The patient has spastic gait, sir, and patient more of weakness more on the left side, sir, compared to right side. Asymmetry is there, and lordosis is there, sir. Where lordosis is.
Planting of the heels and the toes, are there any difference? Is there any difference? I can't see from here very clearly. Okay. Yeah. Now we see. Does he have a extension of the toes when he walks? Great toe.
Sir, because of spasticity, he is dragging the.
Okay, I'll tell you.
Having...
See, Professor UMS Meenakshi Sundaram has a collection of cases of stiff person syndrome, right?
Okay. Okay.
And he makes it a point that these people have extensor of the toes when they walk.
Okay, sir.
And that is a sort of a unique feature in stiff person syndrome, to have extensor posturing. And the reason why,
sir, actually,
another reason also, I'll tell you now. Pyramidal tract involvement is unusual in stiff person syndrome.
Yes, sir. Yes, sir.
And I just want to know whether he always has his great toe extended. So the plantar reflex might be misguided. That is why I asked you
initially,
about.
sir,
sorry, go ahead.
Sir, actually, initially he had that he is having extensor push of the greater toe, sir. After treatment, while follow up for 2 weeks, he didn't have that, sir. We saw initially having great toe extension, sir. After that, given treatment, he didn't have continuous having great toe on walking, sir. Now it is also
okay,
not
the plantar extensor, was it because the because the toe was already extended, or was it a normal toe which went up on eliciting the plantar?
Sir, it went up on plantar extension. We having tensor fascial contraction also. We felt the patient has fanning also is there, sir.
Okay.
On the
Okay. Two things are unusual. One is the pyramidal tract involvement, and the second thing is the so-called distal weakness. Both are.
Okay, sir.
You can go ahead. You can go ahead and discuss.
So treatment we gave initially methylprednisolone, so 500 mg IV for 3 days, following by tapering dose. Now he is only on 5 mg, sir. And initially we gave IV diazepam 10 mg 6 hourly, followed by we changed it to diazepam. He's on now on 25 mg, sir. That is 212, and baclofen 10 mg BD and pregabalin 75 mg at night, and tablet calcium and vitamin D3, sir. This is after that he is mobilized. He is improved very well, sir. Thank you, sir. Thank you, sir.
Okay. See, I should appreciate you now. I initially asked you about the history and asked you so many details. It was a very good presentation. Very good.
Thank you, sir.
Findings and other things are very good. Now, did you look up and find out about the pyramidal involvement and the distal? If it is a distal weakness, why there should be a distal weakness in stiff person syndrome?
No, sir. Actually, stiff person syndromes can have some CSM, cervical spondylolytic myelopathy. They can present like distal weakness. Other than this, no other data is available, sir. Only this because of this patient can have like a pyramidal pattern of weakness, sir.
Okay.
But patient will have.
I'll come back to that. You did a MRI.
Yes, sir. MRI, no.
And in the MRI, you did not find any involvement of the spinal cord.
Yes, sir. Yes, sir. Yes, sir.
So you cannot say that there is a myelopathy.
Yes, sir. We can't say, sir.
Yes. So you still have difficulty in explaining the pyramidal involvement and the distal muscle wasting. Difficulty still the diagnosis is the same, but this seems to be a little. These are atypical features. If you have any explanation for that, fine. Otherwise, madam, you can go ahead, madam.
Yeah. Dr. Harshavardhan, hello.
Oh, sir.
Yes, very detailed and extensive presentation, very good presentation. So this falls under the group of handicap group of disorders. What are the other manifestations you would like to expect in this patient to do? The patient can present.
Madam, patient can present with diabetes, can be cerebellar ataxia, can be GD65 can associated with cerebellar ataxia, limbic encephalitis, can have epilepsy, intractable epilepsy can have present. Patient can have some neuromyoclonic epilepsy like Batten's disease also can have GD65, madam. And neuromyotonia per se, GD65 can possibility also is there. These are the other manifestation of GD65 65 positive. Yes, ma'am.
Vijayan, are you there? Vijayan?
And
Sir, I am there, sir.
Yeah, you will have to give your comments. I'm sorry I had to act like an examiner when you presented the history. I apologize
Sir,
for that.
it was a nice discussion, sir. I think it made justice to the topic, sir. Clinical neurology forum, because all these days big boys were presenting from ivory towers, only investigations, and so this is the first time I think
you can go ahead with your comments on this presentation, Vijayan, please.
The proper clinical examination. Of course, he hit very widely in the history. I think we can't.
Don't forget about that. You just comments on the case and the presentation. Go ahead. And you give your comments on the case. That's all.
The case is a fantastic case. The only thing I wanted to know: did he have any diabetes or any pre-diabetes?
No, sir. No, sir. Patient didn't have any diabetes.
Pre-diabetes also. Sir, HbA1c was normal.
Yes, sir. But HbA1c 5.8, sir. Actually, son and daughter having diabetes, type 1 diabetes on insulin, sir. And both are vitiligo, sir. But we didn't find him any ANA-IF also negative, sir. Other ANA profile we did because of that, because we thought of.
Did you do anti-GAD antibodies in his son and daughter?
So no, sir. Actually, son, we called him last week. Yes, sir. Yes, sir. Yes,
I think that is also worthwhile pursuing, doing the anti-GAD 65 antibodies in his son and daughter, because they have type 1 diabetes, you told.
Yes, sir. Yes, sir. Both,
that is worthwhile presenting. Then this might turn out to be a very rare presentation. Then I think it's a wonderful case. Nicely discussed, anyway.
Sure. Then, are there any antibodies? Are there any antibodies described for vitiligo? I do not know. Hence, I am asking the question. Are there any antibodies described for vitiligo?
No, sir. Vitiligo per se, I didn't find, sir. Actually, I don't know. I had to search, sir. I didn't see.
Okay. Okay. Thank you, madam. You go ahead, madam.
Suppose this patient doesn't respond to your methyl prednisolone, what is the next line of treatment you would like to offer to this patient?
No, patient, if it is can we give IVIG or plasmapheresis or rituximab, madam. We can use any this of line, second line of agent, madam. IVIG or plasmapheresis or rituximab. That these three can be given in patient in this one stiff person syndrome. We can use in first line as of agent, madam, if not responding to steroids.
Suppose what are the recent drugs which are being used in stiff person syndrome? Immunotherapy. You divide into two, whether it is a supportive measure, whether you want to give it. Now you're giving a supportive therapy and symptomatic. Both
yes,
are there, no?
Yes, madam. Now we can use.
What are the other latest drugs which are approved?
They approved levetrestam also. They approved, madam, recently. Levetrestam for spasms, and we can use levetrestam and gabapentin and newer drugs. I don't know. This literature by rituximab and up to rituximab.
Any of the newer maps you know of? See, if you don't know, you read up and tell us in the next forum. Okay.
Okay.
Thank you.
Sir, I don't know.
All things are about these patients' gaits, whether I am right or wrong. It's not very typical like what we see in the pyramidal gait, because he is putting the heel first. So this is something different. And I have seen one, we were searching the literature yesterday, so I saw one patient with the stiff person syndrome with pyramidal signs, but the MRI, everything is normal. The plantar, they say it could be a pseudoplantar, and because abdominal reflexes may be present. So that's one of the things they have discussed in that one. And another, the drug therapy in stiff person syndrome, we have the GABAergic therapy and immunotherapy. We are doing that once. Another thing is acting on the NMDA receptor. One is a tizanidine has been approved, so they are using tizanidine. That also gives, because it's reducing the glutamate. So that improves the patients with the stiff person syndrome.
Thank you, sir. Thank you for your valuable inputs.
Thank you, sir. Thank you.
Any response from Harshvardhan to what Professor Ishwardas has said?
Oh, sir, that also possible, sir. Pyramidal pattern, because of rigidity and all, patient can have increased tone, hyperreflexia can be seen. But plantar extensor is one is unlikely, sir. This because of this one only we are having confusion in these patients.
Madam, your
Yes,
forum
hello, sir.
now. Your forum. Go ahead.
Yeah, we'll move on with the next, we invite the next speaker for the second case discussion.
Correct.
Dilip Mahajan.
Good morning, sir. Am I audible, sir?
Yeah,
Yes.
Can I start, sir?
yeah. You can go ahead, Dr. Dileepan.
Thank you, ma'am. Thank you.
Mm.
Actually, this is a case which admitted 3 months before, ma'am, in our ward.
No,
It's a case of attack.
okay.
So, myself, Dr. Dileepan Maharajan, ma'am, neurology resident in Madurai. So, regarding the case, she is a 45 years old female. She is a right-handed individual, studied up to 3rd standard, and she is an agricultural worker, and she used to do household work also. And she presented here with the complaints of double vision, difficulty in swallowing, nasal twang of voice, and swaying to either side while walking for 4 days, and weakness in all 4 limbs for 2 days. Coming to the presenting illness, patient was apparently normal before the onset of symptom, and the day prior to the onset of symptom, patient went to work and she finished all her work, and she came back and she did dinner, and she had dinner without any difficulty, and she slept. And next day, when she is waking up, she went to the bathroom. That time, she found out whenever she is seeing the side, particularly the right side, she is having the double vision. But initially, whenever she is seeing straight, she doesn't have any double vision. And this double vision was sudden in onset, and it's disappear by closing one eye. This is initially only whenever she is looking at the right. Then the same day, the double vision started progressing, and by the evening, patient started having double vision even while she was looking straight and while she is looking up. And patient also noticed she could not able to look side without turning her head. And the patient's husband also noticed that patient could not move her eyeball fully. And whenever patient wants to turn, she's turning her head instead of turning the eyeball. And during that time, the patient husband also noticed there is slight drooping of the left eyelid, which is not fatigable and persistent throughout the day. And this symptom is not associated with any blurring of vision or any pain during the eye movement. At the same time, patient also started noticed swaying while going to the bathroom. She was not able to walk straight during that time, and she was swaying to both sides. And this swaying is increasing whenever she is going into a dark room or whenever she is closing eye while washing her face. And while walking, patient has to continuously look at the floor. And whenever she is walking by looking straight, she is having increased swaying. And this swaying increased in the next 2 days. And even patient started having this swaying while sitting and standing. And during that time, patient required support of her husband to walk. And during that time, patient also noticed there is incoordination in hand in form of spilling of food from the hand and smearing of food around the mouth and difficulty in buttoning the blouse. And there is history of wash basin attack present, and this symptom associated with numbness in both feet. And during this time, initially, the patient also noticed there is a difficulty while drinking water. Patient couldn't drink water normally. Whenever she is trying to drink water, she is having nasal regurgitation and cough. And when speaking also, patients having difficulty in speech in form of nasal twang of voice with noisy quality. But patient husband able to understand what patient is talking, and patient also able to understand what her husband is talking. And this difficulty in swallowing increased, and by the evening, patient even could not take solid food. And whenever she is trying to take food, patient developed nasal regurgitation and coughing. And these symptoms started in the morning, and all the symptoms developed by evening. But patient didn't seek any medical advice, and she stayed home for 2 days. But after 2 days, as she couldn't swallow anything, she came to hospital. She got admitted. During admission, we didn't find any weakness. But after admission, the next day, we started noticing patient started having weakness in both upper limb in form of difficulty in lifting arm above head and difficulty in gripping objects tightly, fixing food, and buttoning the shirt. On the same day, the weakness further worsened, and patient started developing weakness in both lower limb in form of difficulty in getting up from sitting position and difficulty in grip footwear. And there is history of slipping of footwear present without her awareness, and there is history of buckling attacks of knees present. And these symptoms worsened for next 2 days. And by the end of 2 days, the patient was not able to walk without support, and she need 2 persons support, husband support and another person support to go to the bathroom. And patient also noticed there is difficulty in rolling over and difficulty in getting up from the bed. And there is also difficulty in lifting the head from the pillow present. And this weakness is a flaccid type of weakness. And there is associated numbness present in the both feet. But patient was able to feel the clothes, able to feel the mosquito bites and coldness of water while washing the legs. And there is no history of neck pain, back pain, or radiating pain in the limbs. There is no history of headache, seizure, memory problem, or altered sensorium. Patient was able to smell normally, able to see normally. There is no blurring of vision. There is no facial numbness, difficulty in chewing or deviation of jaw while opening the mouth. There is no facial asymmetry, deviation of angle of mouth, able to close eyes, able to hear normally, no history of tinnitus, able to protrude tongue normally, no deviation of tongue, and able to clear food from the vestibule. There is no diurnal variation in the weakness, and there is no fatigability. There is no thinning of muscle or twitching of muscles, no history of urinary problem or constipation, no lightheadedness, palpitation, sweating abnormality, dryness in the skin, or syncopal episode, no history of abnormal jerky movements, no diarrhea or vomiting, no weight loss, decreased appetite, no rashes in the body, joint pain, joint swelling or oral ulcer, no knuckle hyperpigmentation. Past history. There's a history of fever with sore throat 1 week before the onset of this symptom, which recovered after 2 days. For this, patient took only paracetamol, and she didn't consult any physician. And there's no history of any similar illness in the past. There's no thyroid problem, heart disease, pulmonary tuberculosis or TB contact. There's no history of prior hospitalization or surgeries, no chronic medication use or native treatment, and there's no history of any recent vaccinations. Patient attained menarche at 14 years of age, regular cycle, no polymenorrhea or dysmenorrhea. She's married and have 2 kids. And there's no history of similar illness in the family. There's no history of abortions. Coming to the summary, she's a 45 years old female without any comorbidity, presented with an acute onset neurological illness following a febrile episode. She presented with binocular diplopia associated with bilateral ophthalmoplegia and partial ptosis of the left eye, flaccid dysarthria and nasal regurgitation, ataxia with dark incoordination and wash basin attack, followed by flaccid weakness in all 4 limbs, which is symmetrical and proximal more than distal, descending type, with associated neck muscle weakness and truncal muscle weakness, with normal higher mental function and autonomic function. So the probable structures involved are, as the patient is having diplopia with bilateral ophthalmoplegia, first I want to include 3rd, 4th, and 6th cranial nerve, and that there is a nasal tongue of voice with dysphagia. So I want to include 9th and 10th cranial nerves. And patient is having ataxia. So the ataxia may be either cerebellar or sensory ataxia, but that patient is having increased ataxia while closing eyes, and there is wash basin attacks and associated numbness is present. So it's a sensory ataxia, but patient is it may be due to either posterior column lesion or either may be due to large fiber lesion, and patient doesn't have any cotton wool sensation in the legs, and there is associated weakness is also there. So I want to put the lesion in the large fiber peripheral nerve, and as there is a weakness of both upper limb and lower limb, which is acid type of weakness. So it's a lower motor neuron type of weakness, and it is symmetrical and proximal more than distal. So the weakness either may be due to muscle or it's maybe due to motor root, multiple motor root. But as the patient is having ataxia, so sensory symptom is there, I want to put the lesion in the multiple motor root. So as the patient is having ophthalmoplegia, lower cranial nerve palsy, ataxia with descending flaccid paralysis in all four limbs. So my differential diagnosis are Guillain-Barré syndrome, variant of a Guillain-Barré syndrome. Next differential diagnosis is the nutritional cause, Wernicke's encephalopathy, or it may be a myasthenia gravis, brainstem demyelination, either it's multiple sclerosis or NMO spectrum disorders. And other differential diagnoses include botulism or diphtheria.
Doctor,
Yes.
why do you
Dileepan
tell it is
Maharaj.
brain? Yes, sir.
No, you go ahead, madam. I'm just telling his name. That's all.
Can you please tell why you told it is brainstem demyelination?
Ma'am, there is a lower cranial nerve involvement is there, ma'am. There is a 9th and 10th cranial nerve involvement, and the onset is actually subacute onset, and it's progressed for 2 to 4 days.
Okay, but why do you tell it is MS and NMO?
Is the sorry, Dileepan,
Yes, sir.
does the ophthalmoplegia and lower cranial nerve palsy indicate it's a brainstem involvement, or is there something else?
No, sir. Actually, 9th and 10th cranial nerve involvement is more common in brainstem demyelination, sir, in MS.
It can be
But,
outside the brainstem. No, it can be outside the brainstem.
Yes, sir. It's intraxial or extraaxial, sir.
Hmm.
But actually, 3rd, 4th, 6th nerve involved and 9th, 10th. So it's an extraaxial, sir. Intraaxial with this much big lesion, patient will have unconsciousness or other altered sensorium.
No. Sir is asking, why do you tell it is extraaxial and not intraaxial? What are the points favor for intraaxial and what are the points favor for extraaxial? Intra versus extraaxial, you tell us the differences.
Yes, sir. Yes, ma'am. It's an extraaxial, ma'am, because intraaxial, usually this much long tract sign will be associated, long tract sign will be there, ma'am. So patient will have corticospinal tract sign or spinothalamic tract involvement will be there.
Symptom, not sign. We are only discussing symptoms.
Symptoms.
So there will be loss of pain and touch temperature will be there, ma'am. If the corticospinal tract is involved, if spinothalamic tract is involved, or if corticospinal tract is involved, there will be associated weakness. In pyramidal pattern of weakness will be there, or there will be associated other structures, nearby structures in the brainstem will be involved, sir. In intraaxial.
We are still in the history. We don't know the pattern of weakness. We are still in the history. We're not gone to the examination to tell the pattern of weakness. You told it is a flaccid weakness, acute onset.
But it is symmetrical and proximal.
Dileepan, sorry.
Yes, sir.
One question. See, you mentioned ophthalmoplegia, lower cranial palsy as features of brainstem, but you forgot ataxia. What about ataxia? Why are you not discussing ataxia? That is more
Yes, sir.
interesting for a brainstem, intra or extra or whatever you want to say.
Yes, sir.
But you missed out that. That is the one which gives you the clue, the conglomeration of all these, which makes you think of a brainstem. So ataxia
Yes,
is
sir.
important. You have to
Yes, sir.
discuss ataxia.
Yes, sir. In MS, usually they will present with a posterior column involvement.
Forget the pathological diagnosis, forget the disease entities. What about
Yes,
the
sir.
ataxia here? We are talking of anatomical structural involvement. So where does the substrate where can be the substrate when there is an ataxia?
Yes, sir.
Anatomical structure.
Yes, sir. Ataxia is either due to cerebellum or it's due to sensory ataxia or vestibular ataxia, sir.
Yeah.
So
Go ahead. And so
in this patient, this ataxia even the patient walking also, patient is having swaying side by side, but this ataxia is increased whenever the patient is closing the eyes and whenever the patient is walking in the dark, which is classical of sensory ataxia. And there is associated numbness in the feet is there. So I want to put the substrate in the, it's a sensory ataxia. I want to put it as a sensory ataxia, sir. So for the sensory ataxia, the substrate is either in the posterior column or it's in the peripheral nerve, large fiber, sir. So as it's in the posterior column, the patient usually have associated cotton wool sensation will be there, which is not present in the patient. And for the large fiber, the patient will have associated weakness and weakness will be there. And weakness and
Large
ataxia will be
fiber,
there.
1 minute. For large fiber involvement, why should we have weakness? We are talking of sensory involvement. Why should there be weakness? See, you should not commit yourself. See, as I said, this is an example of you're taking an exam. You should not commit yourself unnecessarily. Why do you bring in a weakness when you are discussing a sensory involvement, large fiber involvement? Is a large fiber involvement associated with weakness? Don't commit like that.
Yes, sir.
See, what you have to discuss is you have mentioned three symptoms: ophthalmoplegia, lower cranial nerve palsy, ataxia. We'll come
Yes,
back
sir.
to descending flaccid weakness later. Now,
Yes,
Tamil
sir.
Pavai madam asked you, where is your likely involvement? Where is the likely involvement? You initially said brainstem. So when you said the brainstem, my question was, with ophthalmoplegia and lower cranial nerve palsy, how do you localize to the brainstem? What I wanted from you is to include ataxia also into that. Okay, now that you
Yes,
have
sir.
included ataxia, now still going by your discussion, ophthalmoplegia, where do you think can be the ophthalmoplegia? Where is the lesion for ophthalmoplegia? Let's take each one.
Yes,
Where
sir.
do you think is the
Either
likely lesion for ophthalmoplegia?
ophthalmoplegia, either it's a supranuclear, nuclear, or infranuclear lesion, or it's in the neuromuscular junction or muscles, sir. Ophthalmoplegia. So
Do
it's
you,
not
1
muscle.
minute, 1 minute, sorry again. Do you get ophthalmoplegia and supranuclear lesions?
Gaze palsy we will have, sir, in supranuclear
Like,
lesion, not ophthalmoplegia.
is it equivalent of ophthalmoplegia?
No, sir. Ophthalmoplegia
See,
is
you should be careful in your discussion. I can lead you on to anything else, but you should not commit. This is precisely what happens in the examination. On the flow, you start saying everything. Supranuclear, nuclear, infranuclear. Does ophthalmoplegia happen in supranuclear lesions?
No, so supranuclear
Okay.
gaze palsy, not ophthalmoplegia. So it's nuclear.
So don't mention that. So where
Yes,
do
sir.
you localize for ophthalmoplegia?
Nuclear, infranuclear, neuromuscular
Where do
junction
you
or muscles, sir.
localize? Where do you localize?
In this patient, I want to localize in third, fourth, sixth cranial nerve, sir, infranuclear part.
You are localizing in the cranial nerves.
Cranial nerve, sir. Yes, sir.
Okay. What about lower cranial nerves?
Lower cranial nerves also 9th, 10th. I want to localize in the 9th,
Okay.
10th
So what
cranial
are all
nerves.
the cranial nerves? What are all the cranial nerves that are involved? I'm sorry,
This
I'm
patient-
misleading you. This is exactly what happens in an examination. I don't need to lead you to the down the garden path. I can take you in any direction. So what are the cranial nerves that are involved?
Third, fourth, sixth, and 9th, 10th cranial nerve is involved, sir.
Okay. So it's a
Polycranialis, sir.
yeah, polycranial
Cranial
neuropathy. Okay.
Neuropathy, yes.
Now fit in the ataxia to that.
This ataxia is due to
No, sir is not asking what is the cause of ataxia. Where you want to localize this ataxia?
wants to localize in the large
I'm not
fiber.
making it easy. I'm not making it easy for you, Dileepan. I'm making it difficult for you.
Yes, it's in a
Go
peripheral
ahead.
nerve, sir. I want to
Okay.
put in peripheral nerve.
Okay. So in other words, what are all the structures that are involved?
In this patient, cranial nerve 3, 4, 6, 9, 10, and the peripheral nerve is involved, sir. Large fiber.
Okay. Right. Fine. So what would you think? Why did you localize to the brainstem then? You see how the discussion can go on.
Yes.
I'm not disputing your brainstem. I would have also localized to the brainstem with this presentation. But I can lead the discussion in any direction. Now, since we have split it, you have multiple cranial nerve palsies and peripheral nerve involvement. Am I right?
Yes, sir. Yes, sir.
So Where does this go? It's a multi-axial involvement,
Yes, sir.
or predominantly it is a peripheral involvement.
Peripheral nerve involvement, sir.
Yes. Okay. But
Yes, sir.
supposing you also have to discuss, supposing this ataxia is not a sensory ataxia.
Yes, sir. If it is a cerebellar ataxia means, then cerebellar ataxia or posterior column ataxia, if you are taking it as this one, then we can put it in brainstem demyelination, sir. Maybe due to.
No, don't go in for demyelination. We're not talking of the pathology. We are talking about the anatomical involvement, site of involvement. So you, for this presentation, leave alone the descending flaccid weakness. We will come to that. For this
Yes, sir.
presentation, it can be at multiple sites involving multiple cranial nerves and peripheral nerves or peripheral radicals.
Yes, sir.
Or it can involve, can this happen with a single structure involvement?
Single structure.
Single site involvement. Difficult, isn't it?
Yes, sir.
Difficult. Why? What is the
Because-
difficulty in explaining with a single site involvement?
Because ophthalmoplegia, that nucleus, everything is in the midbrain, sir. And the
Yeah.
nerves are in that for
Yes.
6 and lower cranial in medulla.
Okay.
And ataxia, we need cerebellum or posterior column. So,
Yes.
single
So
structure
what
we
is the
can't-
difficulty in explaining in a single structure involvement, single site involvement? Tamil Pava madam, please excuse me. You can butt in whenever you want.
I really love the way you're taking classes. I'm just enjoying your discussion, sir.
You can butt in anytime.
Yes, sir.
Yes.
Yes, sir.
Yes, Dileepan. நீ முதல்ல சொன்னது கரெக்ட் ஐயா. நான் கேள்வி கேட்கிறேன்றதுக்காக பின் வாங்க கூடாது. You should be firm in what you are saying as long as you know what you are saying. I am only leading on to what you said initially. So single site எங்க இருக்க முடியும்?
brainstem, sir.
Exactly. It can be in the brainstem. You can explain the ophthalmoplegia, you can explain the lower cranial nerve palsies, you can explain the
Ataxia also we can.
ataxia provided it is not in the peripheral nerve. Right?
Yes, sir.
If the ataxia is either, as you said, vestibulocerebellar, or due to posterior column,
Posterior
the
column.
lemniscus involvement, it can still be in the brainstem. So that is only one site of involvement. But if I ask you to dissect it out and take it individually, you have to consider other sites of involvement also. Now,
Yes,
now see, you are given, now you go to pathology for now talk about the descending flaccid weakness. Where is that involvement? Can it be in the brainstem? Can a
Yes, sir.
brainstem involvement itself cause that?
Flaccid weakness, yeah, brainstem involvement can cause flaccid weakness if patient is in spinal shock, sir. But symmetrical weakness, proximal more than distal, is unlikely, sir. Usually, brainstem lesion will cause distal predominant weakness.
You are running, you are mixing everything together. You said spinal shock, you are talking of brainstem, usual brainstem lesion. Now tell me about spinal shock. What will be the distribution of weakness in spinal shock?
Weakness will be predominant in distal, sir. Distal more than
Is
proximal.
it spinal shock, Leah?
Spinal shock, sir.
Now what is spinal shock? What happens in a spinal shock?
When there is a sudden insult to the corticospinal tract.
No. What happens in a spinal shock? Why corticospinal? What happens in a spinal shock? Where do you get a spinal shock? Where have you seen it? I'm just taking it exactly as it happens in the exam.
Yes, sir.
I'm sorry, I'm deviating, digressing. Where do you get a spinal shock? Because you are putting in words just like that. This is exactly what happens in the exam. You use unnecessary words, you commit yourself, and then depending on the examiner, he can lead you, he can ask questions, make it very uncomfortable for you. What is spinal shock? Where do you get spinal shock?
Acute corticospinal lesion, sir. When there is acute
Why
lesion
should
in the
it be only corticospinal lesion?
human lesion, acute.
Spinal shock, have you seen patients in spinal shock?
Yes, sir.
What will be the neurological manifestations or presentations in spinal shock?
Patient will be in hypotonia with weakness, sir.
நீ கார்டியோ ஸ்பைனல் ட்ராக் சொல்ற, இப்ப அவரு போன கேஸ்ல பிரைமரி லேட்டரல் ஸ்க்லரோசிஸ் சொன்னாரு, அதெல்லாம் ஸ்பைனல் ஷாக் அப்ப if it is acute in onset.
When there is acute involvement,
let us say acute myelitis or the myelitis which is involving only the pyramidal tract, is it a spinal shock?
No, sir. When there is acute involvement, that
So what is a spinal shock then? See, the question arises because you say differentiated distal involvement, proximal involvement, and you mentioned something else. You brought in spinal shock. You said it was not brainstem. It can be brainstem. Why should brainstem cause spinal shock problem? Right? Brainstem can cause a quadriplegia. Right? Why a spinal shock? Quadriplegia. So are you saying here, I was asking you, can you explain the descending flaccid weakness in all the 4 limbs with a brainstem lesion? You can say yes, no, or there may be multiple sites of involvement. It's your choice. If you say it's his brainstem, tell me why should it cause descending flaccid weakness? Why should a brainstem cause descending flaccid weakness?
it in that peripheral nerves, sir, because symmetrical weakness. This is symmetrical weakness and proximal more than distal weakness.
So we do not
So
know. We have not examined the patient yet.
Yes, sir. And by history wise, it was a descending weakness, and it was initially involving the upper limb, then lower limb. And the weakness also, as per patient history, it's more in the proximal muscle than the distal muscles, sir.
Okay, so
And it's
so what do you think it is? And it evolved over a period of 48 to 72 hours.
Yes,
correct?
sir. Yes, sir.
Yeah, the first the bulbar presentation came on within a day or 2, and then
One day,
2
sir.
days
Bulbar
later.
is
2 days later, 48 to 72 hours, you got the other involvement of the limbs.
yes, sir.
Yes. So what do you think now? Is it a brainstem involvement or is it something else?
No, sir. This one flaccid weakness I want to put in LMN axis, sir.
Yeah, where?
So it's a symmetrical weakness. Both proximal more than distal weakness, sir. So it may be either muscle or radical, sir. So muscle, as there is ataxia already, a sensory involvement is there. I want to rule out the muscle, sir. So I want to put in radical, polyradical.
No. Wait a minute. The ataxia, you already said sensory involvement is due to, you think the sensory involvement is due to a radicular involvement?
Large fibers, sir. Sensory involvement is due to large fibers.
Okay. Agreed. So you want to club those two together.
Weakness with large fibers, yes, sir.
Okay. Madam, you can take over, madam.
No, you put all to this together and localize.
Yes, sir. It's ophthalmoplegia and
acute onset with the ophthalmoplegia, lower cranial palsy, ataxia, and descending weakness. Putting all the structures together.
Yes, ma'am. It's a peripheral nerve disorder, ma'am. Ophthalmoplegia and lower, it's a 3rd, 4th, 6th, and 9th, 10th cranial nerve, peripheral cranial nerve, and ataxia is due to large fiber, and the weakness is due to involvement of both large fiber and radicals, ma'am, polyradicals.
No, involvement of large fiber causes ataxia or weakness.
It can cause both, ma'am, large fiber, ataxia and weakness, both it can cause, ma'am, large fiber.
Now, this weakness, you are localizing this descending flaccid weakness, no, to which structure?
This one I am putting it to radical, polyradicals, ma'am, motor roots.
So you want to put to motor roots, polyradiculopathy.
Yes, ma'am.
So putting all these structures, what is your local diagnosis now?
So it's a MFS with GBS, ma'am. Miller-Fisher syndrome as ophthalmoplegia, lower cranial palsy with ataxia. So it's a Miller-Fisher syndrome with a descending flaccid paralysis with polyradical involvement. So it's a GBS. So it's a case of Miller-Fisher syndrome with the GBS, ma'am. One possibility. Then another one, ophthalmoplegia with ataxia, and weakness can occur in encephalopathy, Wernicke's encephalopathy also. But patient usually have altered sensorium. So here altered sensorium is not there. So I'm keeping it as a second diagnosis. Ma'am.
Can it be because of brainstem encephalitis?
And because of brainstem encephalitis, usually patient will have a hypersomnolence, ma'am, and there will be altered sensorium will be there, and weakness won't be there, ma'am, in because of encephalitis. Usually patient will present with ophthalmoplegia with ataxia with altered sensorium, ma'am.
If the patient presents with weakness, what will be the pattern of weakness?
Yeah, which one in because of encephalitis, ma'am?
There will be long track signs.
Yes, ma'am. It's no.
Then go ahead.
Examination, ma'am.
No.
Yeah.
Why do you think of MS and NMOSD with this presentation? It all points for and against. With this presentation, will you consider brainstem demyelination? Okay. Why did you consider specifically MS and NMOSD? Do we get a pattern like this?
No, ma'am. But MS can present initially with ataxia, ma'am. Initial presentation ataxia, then it can involve other lower cranial
Now,
nerve
how
structures,
common
ma'am.
ataxia is a presentation of MS, ophthalmoplegia is a presentation of MS, lower cranial nerve palsy is a presentation of MS. Do we get ophthalmoplegia in MS, lower cranial nerve palsy, ataxia as an initial presentation, acute onset?
Ataxia can be present, ma'am, in MS, but other lower cranial nerve palsy and ophthalmoplegia is rare, ma'am.
In NMOSD?
NMOSD also usually the patient will presentation is weakness, ma'am, weakness of limbs, usual presentation, and ataxia usually it's not seen in NMO, ma'am. It's more seen with multiple sclerosis.
But for all the multiple localizations, you told, all these ophthalmoplegia, lower cranial nerve, and all this doesn't occur in an MS or an NMOSD with so much of acute onset, and this is not the most common presentation.
Yes, ma'am.
Then you put myasthenia gravis. Now discuss about this myasthenia gravis. Why did you consider myasthenia gravis in this patient?
Because this that ptosis was asymmetrical ptosis, ma'am, and patient initially presented with an asymmetrical onset of.
All these points are well taken. Ophthalmoplegia, lower cranial nerve palsy, descending weakness,
Yes,
ataxia.
Ataxia won't occur, ma'am. Ataxia won't occur. That is the one which is differentiating, ma'am, and myasthenia gravis. Other can occur. Ophthalmoplegia, lower cranial nerve palsy, and flaccid paralysis can occur, but ataxia won't be there in myasthenia gravis.
Now your differential diagnosis in the order of priority. Tell. Now you localize to multiple cranial nerves and polyradiculopathy. Now your differential diagnosis. What is your first differential diagnosis?
GBS variant, ma'am. MFS GBS overlap syndrome.
Second?
Second one is nutritional Wernicke's encephalopathy, ma'am.
So botulism and diphtheria, do you get this presentation?
Botulism, diphtheria, usually descending weakness will be there, but botulism, there will be pupillary involvement, but ophthalmoplegia won't be there, ma'am. And lower cranial nerve palsy is rare. And diphtheria also, there is descending palsy will be there, but other things won't be there, and there will be associated fever or diarrhea history will be there, ma'am, in diphtheria.
In not all cases. Then what happened? Botulism, what is the classical finding? Pupillary involvement, no?
Pupillary involvement. Pupillary involvement will be there in botulism.
Can it be a pharyngocervicobrachial variant of GBS?
Yes, ma'am. But in pharyngocervicobrachial variant, that upper limb involvement will be predominant, ma'am, comparing to the lower limb, and the ophthalmoplegia won't be there. When it is involving with the Miller-Fisher syndrome, it can occur, but usually pharyngocervicobrachial variant, it involves lower cranial nerve, 9th cranial nerve with the upper limb involvement, ma'am. The lower limb will be not involved.
Can it be any poisoning?
OPC. Organophosphorus poisoning can cause weakness, ma'am, flaccid weakness with cranial nerve palsy, but ataxia.
Okay. So still you can have a consideration of organophosphorus poisoning also in your differential diagnosis. I'll tell you at the end of the presentation why I'm telling this. Okay.
Yes, ma'am. Yes, ma'am.
Did you ask poisoning history in this patient?
Yes, ma'am. We asked the history, ma'am. I didn't include, but there is no history of poisoning, ma'am. Patient was not telling any history of poisoning. Even snake bite history also, we asked snake bite also, she denied. There is no history of snake
Another
bite.
thing you should all consider snake bite and poisoning, no?
Yes, ma'am. Snake bite also we asked. There is no bite, ma'am. Snake bite
No
was
snake
not
bite, no poisoning.
there. No
Okay.
poisoning.
Yes. Now proceed to the examination.
Yes, ma'am.
A good discussion, Dilip. Very good. Go ahead.
Yes, sir. So on examination, patient is conscious, oriented, cooperative. There is no pallor, cyanosis or clubbing, no pedal edema, icterus. There's no neurocutaneous marker, no markers of tuberculosis seen, no peripheral nerve thickening. On examination of the tonsils, it's normal. No oral ulcer or skin rashes. Fatigability test negative. On checking BP, on supine position, the BP was 110 by 70 millimeters of mercury. On sitting position, the BP was 100 by 70 millimeters of mercury. Standing position could not be checked as patient was having severe weakness. And pulse rate was 92 per minute, regular. Respiratory rate 16 per minute, abdominal thoracic type. And patient height is 152 centimeter, weight 53 kg, BMI 23. Height neck ratio is 13.2. And single breath count for the patient is 20. And higher mental function examination, patient is conscious, oriented to time, place, and person. Mini mental state examination score 20. Memory, language normal. Speech is dysarthric, associated with flaccid dysarthria with nasal twang of voice. There's no delusion or hallucinations. And cranial nerve examination, olfactory now able to smell normally through each nostril. And optic now, the visual acuity was 6/6, color vision and field of vision normal, and fundus normal. And TAD for 6 cranial now, there's an asymmetrical partial ptosis present, which involve left more than the right, and extraocular movement involvement, individual muscle examination for both right and left eye. The movement restricted in all directions, elevation, depression, abduction, and adduction, extraocular movement in individual muscles restricted, and which is more in the right side comparing to the left. And when examining the saccades, pursuit, and Wokian could not be tested due to the extraocular movement restriction. There is no spontaneous nystagmus seen. A pupil size and shape normal, and direct and indirect light reflex present. And trigeminal now, muscles of mastication normal, facial sensation normal, corneal and conjunctival reflex present, jaw jerk absent. And facial now, patient was able to raise the eyebrows, able to close eyes, but not able to close eyes tightly, able to withdraw in examination. Nasolabial folds normal, able to show teeth, not able to hold air tightly in the mouth, and taste sensation in the anterior 2/3 of the tongue normal. 8th cranial now able to hear normally. Rini, air conduction is better than bone conduction, and Weber is not lateralized. Fukuda star working test could not be done. Dalsey reflex is absent. And 9th and 10th cranial now, uvula is in midline, palatal movements absent, gag reflex absent, and nasal twang of voice present. 11th cranial now, not able to struck shoulder against resistance, and there is neck muscle turning the head to side, there is weakness is present. And 12th cranial now, tongue, there is no atrophy or fibrillation, no deviation while protruding, and power of the tongue muscles normal, and on palpation, tongue tone normal. Motor system examination, bulk, there is no obvious muscle wasting. On measurement, arm is 24 centimeter bilaterally, and forearm 22 centimeter bilaterally, and thigh 36 centimeter bilaterally, and leg 25 centimeter bilaterally. An examination of the tone in the shoulder, elbow, wrist, hip, knee, and ankle is hypotonic. And examination of the power, and power in the neck muscles, both flexion and extension knee weak. In this, flexion is weaker than the extension. An examination of the upper limb, shoulder, abduction, adduction, flexion, extension, and internal rotation, external rotation 4/5. In elbow, flexion and extension 4+/5. Wrist, flexion, extension, ulnar deviation and radial deviation is 4+/5. Hand grip is weak. In this, proximal weakness is more than the distal weakness, and it's symmetrical in both sides in upper limb. In the lower limb, hip, abduction, adduction, flexion, extension, internal rotation, external rotation is 4/5 in both sides. Knee, flexion, extension 4+/5 both sides. Ankle, dorsiflexion, plantar flexion, inversion, eversion 4+/5 both sides. And toe grip is weak. And here also, the weakness is symmetrical in both sides, and proximal is more involved than the distal. And superficial reflex, corneal and conjunctival reflex present, abdominal reflex absent, and plantar flexor. And deep tendon reflexes, trapezius, pectoralis, biceps, supinata, triceps, knee and ankle jerk absent. And primitive reflexes are not present. An examination of the coordination, finger nose test and finger nose test impaired. And when closing the eyes and doing, there is increase in incoordination. And dysdiadochokinesia present, knee heel test impaired. Coming to involuntary movement, that is pseudoathetosis in the finger present when patient is extending the hand with closing the eyes. There is pseudoathetosis in the fingers. Ramberg positive. And gait, the patient is having ataxic gait, which is patient is walking with a wide based gait with walking with the visual cues. A sensory system examination, pain and temperature examination normal, vibration sense it's impaired up to knee level, and spinal vibration is normal, and joint position sense impaired in both the big toes, and cortical sensations normal. Cerebellar function test, there's no head titubation, no nystagmus or square wave jerks noted, no cerebellar kind of dysarthria, finger nose test and finger nose test impaired, dysdiadochokinesia present, rebound phenomenon present, stance and gait ataxia present, knee heel test impaired, no pendular knee jerk, and tandem walking could not be tested in the patient. Spine and cranium examination normal, no spinal tenderness, no meningeal signs. On perirectal examination, anal tone normal, anal reflex present. Other system examination, CVS S1 S2 present, no murmur. On respiratory system, bilateral air entry present, normal vesicular breath sound present. On palpation of abdomen, soft, and there is no organomegaly. This video explaining the finger nose test. Here we can see there is incoordination, and this is increasing when patient is closing eyes. And we didn't take the video when the patient was closing the eyes. This video is for the gait ataxia. Here walking, we can see the patient is walking with a wide based gait, swaying to either side and walking with the visual cues. This we are checking the Ramberg sign in this patient. Examination of the eye movement. So actually these videos taken after the treatment, sir. So there is some improvement in the symptoms was there. Initially patient was having severe ataxia and there is no movement in the eyeball, but after the treatment that symptoms improve a little bit. So during the taking video, there is some movement in the left eyeball was there. So coming to the summary after examination, this is a 45 years old female without any comorbidity, presented with acute febrile illness followed by diplopia, dysphagia, nasal twang of voice, ataxia, and descending flaccid quadriparesis. So examination revealed there is a flaccid dysarthria with bilateral external ophthalmoplegia, asymmetrical partial ptosis, weak facial muscles, absent palatal movement and absent gag reflex, flaccid areflexic quadriparesis, sensory ataxia with positive Ramberg, impaired vibration and joint position sets with normal higher mental function, spinothalamic sensation, and autonomic function. Yes, ma'am.
After
Can I
this,
go to investigation?
after the summary, where you want to localize? There is any change from the localization between the history and the examination after examination?
After examination, only there is a subtle weakness in the facial muscle is observed, ma'am. Otherwise, there is not much change in the structures, ma'am. In history, she didn't give any facial weakness, but on examination, there is she couldn't close the eyes properly, and she couldn't keep the air in the mouth. So I want to include only the facial weakness. I want to include, ma'am.
So after
Otherwise, other
the
structures are
examination, also the structures involved are the same, or you want to change the localization anyway?
same structures, ma'am.
Two?
Both peripheral nerve, ma'am. Multiple cranial nerves with peripheral nerve. Large fiber.
Or radical?
With a radical, ma'am. As there is areflexia, I want to include a radical also, ma'am. Radicals with peripheral nerve involvement.
Sir, now can we proceed to the investigation, sir?
Oh, go ahead, madam. Go ahead, please.
Now we proceed to the investigation.
Yes, ma'am. So on investigation, blood investigation shows, and hemoglobin is 9.8.
No, there's only one thing. There's a query in the chat box whether there is cerebellar involvement or not. Somebody is posted in the chat box. They
Yes,
have
ma'am.
asked
Cerebellar
about two questions. One is your oculocephalic maneuver, whether it is needed for
Yes.
this patient, not needed. Another one thing, what is your whether cerebellar involvement are there? The chat box.
Yes, ma'am. Cerebellar involvement. This patient actually have ataxia, stance ataxia, and gait ataxia was there, ma'am. So it may be either due to cerebellum or it either due to
No,
posterior
you're
column or
presenting,
large fiber.
no, you're presenting the case after examination. So after the examination, where you want to localize this ataxia?
I want to localize in large fiber only, ma'am. As there is increasing in ataxia after closing the eyes is there, and there is no cerebellar kind of dysarthria, no nystagmus was there.
Then another
So I want
question they asked about oculocephalic maneuver, whether it is needed for this case, not needed. Oculocephalic maneuver.
Oculocephalic maneuver is usually to differentiate between supranuclear and infranuclear lesions, ma'am. So this patient is already it's a infranuclear lesion, so it's
So it is not
needed, ma'am.
okay. Proceed on with the investigations.
Yes, ma'am. On routine blood investigation, it was normal. CBC hemoglobin was 9.8 with total leukocyte count 8,200 with platelet 2.4, and ESR was on the higher side 55, and urea creatinine normal, and patient's potassium was 3.7, and LFT was normal, and TSH thyroid hormone is 2.45, and calcium was 9.4, and other viral markers were negative, and VDRL is negative. And cardiac echo done, it's normal steady, ECG normal, and ultrasound abdomen done, it was showing only fatty liver, and chest X-ray normal. Vitamin B12 level was done, which was normal, 350 picogram, and peripheral smear shows microcytic hypochromic cells with pyrocitosis, ANA negative, and CRP was positive. And CSF analysis done for the patient. That CSF, the protein was 78 milligram, sugar is 87, cell count nil, and gram stain doesn't have any organism, and culture there is no growth. CSF viral markers done, which is negative, and CSF ADI was 8 units per liter, and CSF CB net is negative, CSF oligochronal band negative, and serum for anti-GQ1B antibody is positive for this patient. And MRI brain done with contrast. This is T2 axial section of the MRI brain. This doesn't show any abnormality. This one is T2 flare, and this one is post contrast, T1 post contrast, and MRI brain doesn't show any abnormality. And nerve conduction study, this done as soon as the patient got admitted in our ward, started having weakness. So 4 days after the symptom onset, we did the NCS. That NCS, there is CMAP amplitude, motor exam CMAP amplitude was normal, and the latency and conduction velocity was in the normal. And when we are doing SNAP, the medial ulnar and sural SNAP was not obtained, and F5 latency was prolonged in this patient. And when doing RNS, it was normal. So, concluding as there is in investigation, there is anti-GQ1B positive, and CSF was showing albinocytological dissociation.
Now, how common is the sensory abnormalities you get in nerve conduction studies in a patient with MFS?
Actually, MFS, it's rare, ma'am. Usually, the patient nerve conduction studies will be normal, or it may show a minimal CMAP amplitude, decrease in CMAP amplitude, but the SNAP is usually rare, ma'am. But this patient,
what is the SNAP pattern in GBS? This is a typical SNAP finding in the GBS?
No, ma'am.
What is
usually
what
SNAP
is
will
SNAP
be
finding?
normal in it will be normal in GBS with CMAP will be reduced or absent, ma'am, in GBS usually.
No, I'm asking only about the SNAPs. What is the classical presentation of SNAPs in GBS?
Dileepan, you should
sir.
understand the question. The question is not about MFS. The question is what is the pattern of sensory nerve action potentials in a case of GBS?
Usually there will be sural sparing pattern will be there, sir.
Yeah.
Answer, madam.
GB.
Madam is the one who asked the question. Yeah.
Yes, ma'am.
Yeah, yeah.
Sural sparing pattern will be there in GBS.
Sural sparing will be
So
there,
you
but
don't
what
get
will
it?
be affected?
Other upper median and ulnar snap will be affected with
Yeah, tell. With preserved?
preserved sural nerve, ma'am.
In MFS, what are the sensory abnormalities do you get? Okay,
MFS,
proceed. You read up that what are the sensory abnormalities which you get in MFS
Yes, ma'am.
in a nerve
Yes, ma'am.
conduction study.
Yes, ma'am.
Anything you want to tell more about this MFS GPS overlap? How common is it?
Actually, this is a rare syndrome, ma'am. Usually, MFS will occur separately or GBS will occur separately. In even MFS criteria, they didn't include a weakness. The patient should have a ataxia with ophthalmoplegia with absent reflexes without any weakness. That is the criteria for MFS. But in some patient, it can overlap with GBS.
What are the other variants of MFS you know of?
Other variant is MFS with a partial MFS syndrome, ma'am. It is either only acute ophthalmoparesis can occur or acute sensory ataxia can occur, or that patient can present with Bickerstaff encephalitis. That also one of the variant of MFS.
No, the Bickerstaff encephalitis is a spectrum of anti-GQ1. I'm asking what are the other variants? You're partially right.
Yes, acute ophthalmoparesis and acute sensory.
Then patient can present with pupillary abnormalities alone. Patient can present with ptosis alone, ataxia alone.
Ataxia alone, yes, ma'am. Acute ataxia, sensory ataxia, yes, ma'am.
There are 6 to 7 partial variants. Okay.
Yes, ma'am.
Then, sir, anything, sir?
No, I just missed out his sensory conduction. What did you find on sensory nerve conduction? Sorry, can you go over it again? I just missed that.
This patient actually, we didn't get any sensory nerve conduction, sir. Motor nerve conduction was normal, but for sensory conduction, we didn't get any median alertness.
Okay, and sural also was absent. Right, fine. Okay.
Sural also absent and
Right,
FA latency is prolonged.
Thank you. I just wanted to know that. Madam, you can go ahead.
Anything else more you want to tell about this case? What is
Any
interesting?
opinion from the audience also, madam?
Any opinion from the audience also? Any opinion from the audience?
The combination of MFS and GBS overlap. People would have seen that. Yes, please. Yes, Ishwar Das, sir.
Sir, I saw the video. There appears to be a thyroid nodule for this patient. Thyroid is normal, but I think thyroid antibodies could be done in this patient because it's one of the associated findings, collagen disease, Hashimoto's, and also the risk factors for MFS syndrome. And other thing, they say immunization and MFS syndrome or Guillain-Barré syndrome. We say billions of people have been immunized, but what is how to relate this one? We know COVID and Guillain-Barré syndrome, COVID vaccination, Guillain-Barré syndrome, or this MFS syndrome. I don't know how much this is relevant in this patient, sir. And another thing, they say recurrence is more common in MFS than Guillain-Barré syndrome. I don't know. They must correct me. And the Bickerstaff brainstem encephalitis, as described by Bickerstaff, he said it is a grave syndrome with a benign prognosis. So I think even though the presentation may be very morbid, but the patient may improve if properly treated. So I learned many things in this patient. So thank you very much, sir.
So actually post-vaccinal polyradiculopathy, we encountered a lot of cases in MMC, sir. But the problem was they are telling it is only a casual relationship and they're not able to attribute that vaccine causes GBS per se.
Correct. Okay. Thank you.
But we have not seen a case of MFS, sir. We have seen enough number of cases of polyradiculopathy, brain stem demyelination, all with post-COVID vaccination, but they're telling it is just an coincidence rather than attributing it is the cause of COVID vaccination.
This one is a pharyngeal cervical brachial variant Guillain-Barré syndrome. Is that is anyway related to MFS or it's a different syndrome by itself? This one.
So
It's
this-
a different syndrome.
Okay. Thank you.
Thank you, sir.
Maybe we can call this
Issue, sir.
anti-GQ1B
MRI,
syndrome.
they say MRI in Guillain-Barré syndrome, that's thickening enhancement of the intrathecal roots and cauda equina and all have been described. Did you find any of these one in your patient?
No, sir. And this
Uh,
patient, we did contrast, but we didn't find anything, sir.
Thank you.
Ishwar sir, I have one question for you. You said MFS can recur.
Yeah.
How common is that recurrence? Is it more common than recurrence of GBS?
Yes, sir. That's what one of the article they mentioned, sir. Because
Recurrence of MFS.
yeah, MFS is more common than kilometer. I saw it's subject to corrections because yesterday, because I know what are the cases to be discussed. So yesterday night.
That's okay, sir. That's no problem at all. Yes,
So I don't know
we can
whether
look up and
that's
refer
what
and
I'm.
come and prepared and talk. Yes,
Yeah,
that's
yeah.
how we learn more, sir.
Yeah,
What
we
you are
are
doing
old.
is absolutely correct. Yes, sir.
We got old people, sir. We are declining memory. So this, I don't know, it's subject to correction. But it is mentioned like that only. It's a more common. MFS is more common. Recurrence is more common in MFS than Guillain-Barré. I don't know. It must be.
No, it
Right.
depends on, there are so many people here. They can participate and tell us about their experience with recurrence of MFS.
So recurrence of MFS, I have not still seen a case. Even recurrence of GBS, we are yet to see, sir. I've seen just only one case. I'm not very sure, sir, but recurrence of MFS I have not seen, and recurrence of GBS also I have not seen, sir, from my institute.
Professor TP,
Yes, sir.
relapse of GBS can happen.
Yes, sir.
There may recurrence and relapse. Relapse happens, you know, after withdrawal of treatment, some people immediately go for weakness again.
Yes, sir.
That's considered to be relapse unless the time gap is more than 3 weeks.
Yes, sir.
So that can happen. Recurrence of GBS, yes, unusual, but I do not know about MFS. That's why I was asking Professor Ishudas why he did mention that. There are others also.
One of the
they
one
can-
study, sir. It was one study. I don't know. One paper person. I don't know whether
Yes, sir.
I'm right or
Yes, sir.
wrong.
Yes, sir.
As he said, even Guillain-Barré syndrome recurrence, we are not. MFS, you know, it worth presenting that.
Sir,
I
any
like-
other
I
comments
just
from the
look into it,
audience
sir.
regarding
I
recurrence
just
of
looked into the
MFS?
literature of recurrence of MFS, sir, and keep it updated.
Regarding
madam.
recurrence, sir, can
I
I
just
come in?
looked into the recurrence of
Yes,
MFS from
Vijayan. Yes,
literature,
Vijayan,
sir.
please.
I
You are the most
I don't know.
alive person. Go ahead.
Sir, recurrence of GBS I have seen, but recurrence of MFS I have not seen. Of course, MFS is a very rare syndrome again, on the whole. Can we call this as anti-GQ1B syndrome, as they call in kidney and lung? They call
Yes, sir.
anti-glomerular
It is. It
basement
is. It
membrane
is. It is.
syndrome.
It is anti-GQ. He has
And-
already shown anti-GQ1B.
And we can,
Whenever we have atypical features, we club
and
together
instead
as
of-
anti-GQ1B and
Yeah.
say that that's
instead of
anti-GQ.
giving eponyms, we can
Yeah,
just
yes,
like
yes.
they say ANCA-associated vasculitis, and they don't give eponyms for that. So such overlap syndromes can just be called anti-GQ1B syndromes rather than just
I
giving
agree
an
with you.
eponym. Fine, yeah.
Yes,
I
sir.
agree, but happens. Any other comments, sirs?
So what is this recurrence and CIDP, sir? It's AIDP recurrence.
Good question, sir. Good question. Good question. Good question. That is, there can be an acute CIDP and CIDP. Recurrence of GBS can qualify for a CIDP depending on the time frame. That's why I was asking you about recurrence. If there are recurrences which go on beyond the time frame of 4 weeks, which is what we give, for acute AIDPs and CIDPs, then it comes under the purview of CIDP. But a relapse of GBS, which happens as a relapse, that is within 2 weeks of improvement, that is considered a relapse, and that is not considered as a separate occurrence of GBS again. So we have to distinguish between relapse and recurrence. And if the AIDP seems to occur again, then it could be a CIDP. And there are acute CIDPs also. It's considered a CIDP presenting acutely like an AIDP, but prolonging on for more than 4 weeks, manifestations going on for more than 4 weeks, when this is considered to be CIDP. The importance there is regarding the management. In AIDPs, we always go in for IVIG or plasma exchange. Whereas even if it is an acute form of CIDP, we can consider steroids, IV steroids. That's the importance there. Tamil Pave, you can add on, madam.
Sir, is it that the AIDP associated with the concurrent autoimmune diseases, they have more recurrences? Is it like that, sir?
I don't know, sir. A lot of things, as you know, we do not know. I don't know about concurrent autoimmune predisposing to recurrence of AIDP. Again, it all depends on, as Vijayan said, it all depends on what antibodies we have. See, most of it, we have to differentiate AIDP from sporadic, de novo occurring, and also AIDP in relation to a preceding infection. For example, in this person which they presented, there was a preceding infection following which this person had this MFS, which is what we usually see. And of course, the presentation also can vary between AMAN, AMSAN, and mixed involvement, depending on whether there is a preceding infection or not. So several of these things remain unanswered, whether another autoimmune disease predisposed to recurrence of GBS. I do not know. Perhaps somebody in the audience, or Tamil Pave, madam, you can contribute.
What's the recurrence of? Yes, sir. Sorry, sir.
Recurrence of GBS in
Yes, sir.
people who have other autoimmune disorders or other autoimmune antibodies.
Not very sure, sir, because we have not seen any cases with recurrence, sir, in our institute so far.
No, we have seen some other patients with Hodgkin's disease presenting as Guillain-Barré syndrome, and SLE with the presentation with the AID.
That is there, sir, as a first
In that
presentation, but
cases-
recurrence I have not seen, sir.
Yeah, that's what I, okay.
Recurrence I have not seen, sir.
Okay, thank you. Recurrence itself is rare. Okay, thank
Yes,
you.
sir.
Thank you. Anyway, it's good for the patient. Recurrence is not there.
Yes, sir.
One other thing I wanted to point out with regards to relapse is, Tamil Pave and others may also agree, there are treatment-related
Yes, sir.
fluctuations also.
Yes, sir.
So that is also another entity where the presentation can vary, they can fluctuate, they may show improvement, and then again they may show increasing weakness. So in
Yes,
that
sir.
sort of cases, those are the sort of cases where we can repeat IVIG or plasma exchange,
Yes, sir.
ideally.
Yes, sir.
Madam, if there are no comments, you can
Yes.
close the session, madam.
Yes, sir. Any comments from the audience? There are no comments, sir.
Okay, you go ahead, madam. You can close it. Close the session.
Thank you, sir, for giving me this opportunity to chair this session. I thank the moderators, Vijayan sir, Ishwar Das sir, and all the PGs and assistants who have been participated in this. It was a learning curve on a Sunday, and really thank one and all for attending this.
The presentation,
immense-
madam, the presenters, the Department of Neurology of Madurai Medical College, Professor Manivannan and his team,
Yes, sir.
and the presenters, Harshvardhan and Dilip Maharajan. Thank you all for presenting a very good case and evoking a very good discussion. I think we had a very good discussion
sir.
this time.
Yes, sir.
As Madam Tamil Pave and Ishwar Das, others have been, and Vijayan have been saying, it is learning for all of us. So please continue to contribute and continue to come and discuss. Thank you.
Definitely,
Thank you,
sir.
madam. Madam, you did a
Thank
wonderful
you so
job.
much, sir. Thank you
No,
so
no, I
much, sir.
should thank you. You
Yes,
did
sir.
it very well. Thank you. It was again,
Yes, sir.
you are conducting an examination. That's good. That's how it should be done.
Yes,
It
sir.
should be coming from
Yes,
the
sir.
examiners. Good thing that you did. And I thank Sun Pharma also for, as usual, providing the logistic support. Thanks to one and all. Thank you all, sirs and
Yes, sir.
madams. Thank you.
Thank you, sir. Thank you, sir. We'll meet
Welcome,
in the
madam.
next forum, sir. Thank you,
Thank
sir.
you. Thank you.
Thank you.
Karthik, thank you, Karthik.
Sir, thank you, sir. Ibrahim, sir.
Ibrahim இருக்கீங்க. கார்த்திக் யார் வந்திருக்கா? எந்த கார்த்திக் வந்தாரு? டெக்னிக்கல் டீமா?
ஆமா, sir.
Oh, okay. Ibrahim, thank you, pa.
Okay,
Thank
sir.
you very
Thanks, sir.
much.
Thank you.
Right. We can leave, huh?
Okay, sir.
Thank you, pa.
Okay, sir.